Okay.
So very good evening. On behalf of ICOG, I take this opportunity to welcome all our esteemed speakers and you all dear delegates. On day one, we covered the history taking, counseling, the classifications. Day two, female sexual dysfunction. And today is the day 3 and last day of this FOGSI ICOG online course on sexual health, where we are covering male sexual dysfunction. I know everybody has got lot many queries related to pre-test and post-test. So pre-test is just for self-evaluation. It is just for self-evaluation that before starting that day, that particular day's course, how much knowledge you have. And when you are giving post-test, it is again for your self-evaluation, how much knowledge you have acquired by attending all the lectures of that particular day. Let me tell you one thing, just having certificate without paying attention to the lectures or imbibing that practical knowledge is not going to help you in your day-to-day practice. So please pay more attention to the ongoing lectures, interact with your speakers, try to sort out your queries. And Neeraj, we are not posting anything in the chat box related to the pre-test, post-test, no answer key, nothing. So today we will be having pre-test for 10 minutes and pre-test has no link to your certificate. Post-test, yes, it is compulsory. All 3 days post-test, 50% passing marks. And just because you know the ICOG chairperson does not mean that you can call me and you can tell me that I was having emergency, I am having network issues. See, if you want to appear for the exam and you want to have certificate, you have to manage all those issues and you have to give all the 3 days post-test and you have to score 50% marks. Because my hands are tied as ICOG chairperson, I just cannot favor anyone out of the way. Criterias are there for everyone. Yes, certificate as such has no meaning if you don't pay attention and don't learn. So if you have missed post-test, pre-test, please don't bother. Just try to learn and interact with the speakers what is going on. So today, Neeraj, we will not entertain any queries related to pre-test, post-test in the chat box, because most of the delegates, they log in at their own convenience and they join late. They don't pay attention to our briefings and then they repeatedly ask. And because one person has asked, immediately the second person asks the same question. And please, we are not going to share any PowerPoint with you, neither any videos, because this is a learning class, a certificate course. So you have to pay attention to the things by remaining present and interacting. So I hope I'm very clear as far as today's instructions are concerned. So let's start with our scientific deliberations, and happy learning to you all.
So good evening and welcome to everyone. So finally we are here of the last day of our program of the ICOG certificate course on the sexual health. Yesterday we covered female orgasmic disorder, then female sexual interest and arousal disorder. We also have a great session on the genitopelvic pain and penetration disorder by Dr. Padmini. Then Dr. Radwa told us about the sex in pregnancy, which was very enlightening session talk. Then role of by Dr. Ruby, role of cosmetic gynec in sexual dysfunction, which was so many new things we knew from her. What are the various modalities available which we can use in the sexual health? And finally, by Dr. Asa FOGSI Madam, there was a talk on unconsummated marriage. So yesterday was very from 3 hours, we stretch up to the 4 hours. So hopefully today we can cover in the time and put your question in the chat box, but don't put unnecessary comment in the chat box, because it becomes difficult to find the question from the so many chat. So please be pertaining to the only related to the topic and only related to that question, not any insignificant question put in the chat box. It becomes difficult for us to answer queries from the delegates. So we may missed some of the important question from you. So once again, I welcome everyone to today's session, which will today we are going to deal about the male sexual dysfunction. Then there is a non-communicable disease and the sexual dysfunction, then psychiatric component, and most important about the adolescent sexuality component. Also, we are going to learn from today. So today we have a very two efficient moderator with us, Dr. Sama Sultana and Dr. Poonam Misra. So I welcome both of them, and I request Jignesh to start with the pre-test. So yes, madam.
So dear delegates, we are posting the pre-test link in the chat box. Now he has already posted. Just click on the link and start answering. The time given is 10 minutes. Our technical team is starting the timer as well. Meantime, we all will keep ourselves muted so that there is no disturbance for you while you are giving pre-test.
4 minutes left. Two minutes left. One minute. So time is over.
Time up.
Yeah. So if you have joined late and could not finish the pre-test, don't worry. Don't ask for the link of the pre-test because pre-test is only for your self-evaluation. It will be not counted for your certificate. Only post-test is important for the certificate. You have to score 50% in the post-test. And some of the delegates were telling that it is difficult, but all the question will be from the talk only. So listen to the talk carefully. You will get all the query of the all the question of the pre-test or post-test from the talk only. So you will be answer all the question correctly if you listen all the talks carefully, and you will get good marks. So with that note, let us begin today's session of the last day of our ICOG certificate course in sexual health. I request Dr. Sama to start with the today's first talk and introducing our faculty for first talk. Sama, are you there?
Yes, sir, I'm there, sir.
Yeah.
Yes, good evening, all. Starting up with day 3 and final session of FOGSI ICOG online certificate course. So I welcome our first speaker, Dr. G. Rahul Reddy, sir. He is MS General Surgery and done his fellowship in andrology and men's health. He is Professor General Surgery and consultant microsurgical andrologist at Androcare Andrology Institute at Hyderabad, and he served as a faculty in andrology in various national and international conferences. So have bagged many awards as the best surgeon and best andrologist. So he shall be talking on erectile dysfunction, and over to you, sir.
Yeah. Welcome, Dr. Rahul, sir.
Thank you, sir. Thank you, madam, for your kind introduction.
Great.
Yes.
Yes.
Good evening, doctors. Welcome to today's lecture. This is, I think, first lecture today. I'm going to talk about erectile dysfunction, which is a very common problem in most of the males. Now, there is no age limit for erectile dysfunction. Previously, we used to see erectile dysfunction only in middle-aged people or 60 plus people, but it is not the case. Nowadays, we are seeing patients even with 18-20 years with erectile dysfunction. In fact, 60% of our patient load in regular andrology clinics is with young patients with erectile dysfunction. So now, to make you understand what is erectile dysfunction is inability to achieve and maintain an erection adequate for intercourse to the mutual satisfaction of the man and his partner. This is the definition. So now what it means is just getting an erection is not enough, but even maintaining erection is also important. So now when we talk about erectile dysfunction, there is a big confusion. Even many doctors, they get confused between erectile dysfunction and ejaculatory dysfunction. Because sometimes patient will be having premature ejaculation, but they come to us saying that erectile dysfunction, he is having erectile dysfunction. So in sexual dysfunction, we have two types. One is erectile dysfunction, second one is ejaculatory dysfunction. So ejaculatory issues like retrograde ejaculation, premature ejaculation, delayed ejaculation, anejaculation, all those things come under a different category. So coming to erectile dysfunction per se, we have different types of erectile dysfunction. One is hormonal erectile dysfunction, psychogenic, situational, vascular, and neurogenic. In general, we classify them into organic and psychogenic. So in organic, again, hormonal erectile dysfunction, vascular erectile dysfunction, neurogenic, all these things will come under organic ED. So now if you see, most causes of ED were once considered to be psychogenic, but current evidence suggests that up to 80% of cases have an organic cause. So now people coming with only psychogenic ED is very rare. So now this is the classification I was talking about. Organic causes are subdivided into vasculogenic, neurogenic, and hormonal. Vasculogenic etiologies represent the largest group, with arterial or inflow disorders being the most common. So now how to differentiate between organic ED and psychogenic ED? So now when we see a patient with erectile dysfunction, if erectile dysfunction is gradual in onset, it is organic ED. If it is sudden in onset, then most probably this is psychogenic. That means if a patient comes to us and says, doctor, so-and-so date, I'm having erectile dysfunction, most likely that is psychogenic ED. So, and organic ED is always constant, but in psychogenic ED, they'll have very good early morning erections. Only when they try to have intercourse, or sometimes they have normal erections, they'll have spontaneous erections, very good spontaneous erections, but during the sexual act, they may not get an erection. And organic ED, it affects non-coital erections also. That means these people may not have early morning erections or spontaneous erections, whereas psychogenic ED patients will have very good spontaneous erections and early morning erections. And organic ED occurs under all circumstances, but whereas psychogenic ED is associated with presence of nocturnal or early morning erections. So now, what are the common causes of erectile dysfunction, particularly psychogenic erectile dysfunction? One is most common cause is performance anxiety, which is very common in youngsters. They see, whenever they see porn or whenever they discuss with their friends, most probably the friends, the exaggeration from their friends, or after seeing the porn movies, they imagine their sexual activity in a different way. So when they think there is some gap between what they have imagined and what is there in the actual scenario, they get performance anxiety. And second cause is previous failure. Once a man, even though he's normal, once there is failure with particular partner, this failure will haunt him. Whenever he try to have intercourse, that failure will always uh, keeps on disturbing him in his mind. And third one, depression, fatigue, guilt, stress, marital discord, all these are other causes of psychogenic ED, whereas organic ED has various causes like cardiovascular disease, diabetes mellitus, neurological causes, hormonal deficiency. So now, if you see the causes, in general, hormone deficiency and vitamin deficiency, endothelial dysfunction, injury to the penis, all these things can cause organic ED. Apart from this, end organ failure, vascular damage, spinal cord injuries, previous history of pelvic surgeries, substance abuse, alcohol and chronic alcoholics and chronic smokers are more prone for erectile dysfunction. And apart from these things, medications, the regular medications what we prescribe, can also cause ED, and this is seen in 25% of cases of erectile dysfunction. So what are the common medications which can cause ED? Then most common medications which can cause ED are antihypertensives and particularly beta blockers, antidepressants, and hair fall medications like finasteride, dutasteride. These are commonly used by youngsters, particularly when they are in hair loss treatment. This can cause erectile dysfunction. So now, apart from this, CNS drugs, tricyclic antidepressants, SSRIs, tranquilizers, sedatives, anticholinergics, estrogens, ketoconazole, all these things are the medications which can cause erectile dysfunction. So coming to incidence, this is based on American population. In 2% men less than age of 40 years, they have erectile dysfunction. 25% of men less than 65 years and 75% of men more than 75 years, they have erectile dysfunction. But Indian figures are totally different because India is diabetic capital, and you see young patients with erectile dysfunction. So according to our figures, it should be around 30 to 40% in less than 40 years age group. So now approximately 50% of diabetic men and 20% of hypertensive men suffer from some degree of sexual dysfunction. And now ED is associated with diabetes, hypertension, heart disease, medications, depression, psychological factors, and stress. This is what this is the gist of what we discussed in last couple of slides. So now, what is the management strategy? Now, what is different from the previous ED evaluation and current ED evaluation? In previous days, what we used to do, whenever we see a patient with erectile dysfunction, we used to take history and physical examination, then followed by basic evaluation like hormone evaluation and penile Doppler vascular evaluation. And then we used to find out the etiology, and then we used to start treatment for that. But nowadays, it's not so simple. Now ED evaluation has changed. Now, the majority of the patients with organic ED, particularly vasculogenic ED, whether it is arteriogenic ED or venogenic ED, they have risk of future cardiovascular risk. So that is why whenever we see a patient with erectile dysfunction, first we have to do history and physical examination. And if it is an arteriogenic cause or vascular cause, our duty is to find out his future cardiovascular risk. If the risk is on the higher side, we have to refer him to a cardiologist or general physician. Then we have to start treatment for ED. But if the cause is simple hormonal or psychogenic, then we don't have to do cardiovascular risk evaluation. This is only for patients with arteriogenic ED. Why this is important is there are so many studies which says that ED is strongly associated with cardiovascular disease. Now, there is, once we think of cardiovascular diseases, then first thing what we have to think is endothelial assessment or endothelial dysfunction. So now the role of endothelium in human disease recently has become focus of intense scientific investigation. Impaired endothelial function is associated with a number of disease states, including erectile dysfunction, cardiovascular disease, and its major risk factors. So now endothelial dysfunction precedes overt vascular disease by years and may itself be a potentially modifiable risk factor. So what this sentence, why this is important is, see, now there are very few tests for us to find out future cardiovascular disease. Now, whenever there is cardiovascular incident or there is doubt, we are doing ECG, 2D echo, treadmill assessment. But if there is endothelial dysfunction, if we can identify this patient and we can assess his future cardiovascular risk, then actually we are avoiding his future cardiovascular risk. So that is the importance of evaluation, ED evaluation in young patients with vasculogenic ED. So now that is why they say now penis is the barometer of endothelial health, and erectile dysfunction is a mirror of cardiovascular risk. So now key points are endothelial dysfunction is considered to be a major step in atherogenesis. Early detection of endothelial dysfunction may identify subjects at high risk for atherosclerosis. Endothelial function can be evaluated with invasive or non-invasive techniques applied directly into the coronary arteries or in peripheral conduit arteries. And endothelial dysfunction is an independent prognostic factor in patients with advanced atherosclerosis. Asymptomatic subjects with endothelial dysfunction require better control of risk factors. So these are the various studies which say the importance of endothelial dysfunction. See, if you, and coming to this artery size hypothesis, now what they say is, since the penile artery diameter is in the lower side, the ED impairs the blood vessel. Once the blood vessel is impaired, erectile dysfunction will set in. But whereas in cardiac diseases, it takes some time for the plaque to occlude. That is why it takes some time. So this is the stage where you have to stop the damage. So, and if you see the common risk factor, and cardiovascular disease and erectile dysfunction both have common risk factors like increasing age, obesity, male, hypertension, diabetes mellitus, cigarette smoking, high cholesterol, sedentary lifestyle. So now, if you see, according to this paper, early sign of erectile dysfunction is an early sign of underlying cardiovascular disease, and 57% of men who had bypass surgery had prior ED, and 64% of men hospitalized for MI had prior ED. So thus, this shows the importance of ED evaluation. So now coming to evaluation part. So now what are the common tests we are supposed to do when we see a erectile dysfunction patient? We commonly do thyroid profile, testosterone total is enough. No need to do free testosterone, prolactin, vitamin D, and B12, homocysteine, HbA1c, and penile Doppler. So now all these are the basic tests which can independently can cause ED. High prolactin cause ED, low testosterone can cause erectile dysfunction, vitamin D deficiency and B12 deficiency are very common in erectile dysfunction patients. So homocysteine, if homocysteine is elevated, then also it can cause erectile dysfunction. So coming to treatment options, we have medical management, nutraceuticals, hormonal treatment, injection therapies like trimix and bimix, shockwave therapy, and surgical management. So now you have to segregate which patient needs counseling. If it is a patient of clear-cut case of psychogenic ED, even then we have to put him on medications, and we need before giving him counseling. What happens is sometimes when you just give counseling for these psychogenic ED patients, they may not respond. You have to give them some confidence through medications, and then you have to parallelly you have to give counseling for these patients. So, and lifestyle modifications are very important. Like alcohol, either we have to decrease or limit the alcohol consumption, reduce fat, which is indirectly weight loss, eliminate tobacco use and substance abuse, weight loss if appropriate, and regular exercise. Regular exercise, even if you are not doing other things, regular exercise will help in most of the other issues. So now, coming to PDE5 inhibitors, because the moment we talk about erectile dysfunction patient treatment, the first drug which comes into our mind is sildenafil citrate. It's a famous PDE5 inhibitor. Now, apart from sildenafil citrate, now there are various other PDE5 inhibitors. Now, indications for PDE5 inhibitors are psychogenic ED, mild vasculogenic ED, neurogenic ED, and side effects from other medications patient if he's already taking. So now, as I said, this is the chart of PDE5 inhibitors. Now, these are the PDE5 inhibitors which are commonly available nowadays. One is sildenafil citrate, second one is tadalafil, third one is vardenafil, and fourth one is avanafil. So now, duration of action, time of efficacy changes from drug to drug, but contraindications are same for most of the drugs, and timing is again different for each and every drug. So now, coming to doses of these medications, sildenafil citrate is available in 25 milligrams, 50 milligrams, and 100 milligrams. Tadalafil is available in 2.5 milligrams, 5 milligrams, 10 milligrams, and 20 milligrams. Udenafil is available in 100 and 200, vardenafil 10 and 20 milligrams, avanafil 50, 100, and 200 milligrams. But in Indian market, avanafil is available in only two strengths, 100 milligrams and 200 milligrams. So, when you know now how to select a drug when you see a patient with erectile dysfunction, how to select a drug which suits this patient. This is where it is important. Now, if a patient is having severe psychogenic ED, or if you are dealing with a couple with non-consummation, then you have to give them strong doses of medication. In those cases, sildenafil citrate or avanafil or vardenafil, higher doses. If you are putting them on avanafil, it should be 200 milligrams. If it is vardenafil, it should be 20 milligrams. Or if it is sildenafil, it should be 100 milligrams. But most of these medications will have common side effects. Common side effects like headache, flushing, redness of eyes, feverish sensation, headache, back pain. These are the common side effects, and sometimes increased heart rate. These are the common side effects. We have to counsel them about the possible side effects so that patient should not get worried after seeing side effects. So now, when you see a couple with non-consummation, or if your patient is having strong vasculogenic ED or strong psychogenic ED because of performance anxiety, their low dose medications may not work. As I said, you have to give them, start them with high dose medications. Once they have intercourse, successful intercourse, then slowly you can decrease the dosage. But whereas patients with mild ED, ED, that means very low grade erectile dysfunction, then what you can do is you can actually start with low doses of medication to avoid side effects. My favorite drug is tadalafil. Tadalafil is available in 2.5 milligrams, 5 milligrams, 10 milligrams, and 20 milligrams. This can be taken apart. If you compare with other drugs, this can be taken as a daily dosage medication. You can actually start with 2.5 milligrams of tadalafil or 5 milligrams of tadalafil on daily doses, daily once after dinner. This actually improves their confidence, because once they are in daily doses, then they don't have to take on-demand medication. Then they get more spontaneous erections. On daily basis, they see good early morning erections. So they feel confident when they are taking tadalafil. So that is the reason now most of the doctors, they started, andrologists, they started prescribing tadalafil for all ED patients. At least 80% of erectile dysfunction patients, now they go with tadalafil. So doses you can change. The only major side effect with tadalafil is myalgia and back pain. So initially you have to start with low doses. You can start with 2.5 milligrams. If patient is responding well, you can continue 2.5 milligrams for months together. Or if patient says he's not getting very good erection with 2.5 milligrams, then what you can do is you can actually increase the dosage to 5 milligrams. And there is no time limit for these medications. Patient actually can take these medications for months together. And the another advantage with tadalafil is now this is actually cleared by FDA for BPH management. So now in BPH, when a patient in 60+ age group who is having diabetes, cardiac related issues, hypertension, when he can take this on daily basis for lifelong, then that means there is no long-term side effect for young patients. So generally we put our patients on tadalafil for months together, maybe 2 months, 3 months. Even psychogenic ED patients, this drug works very well because it boosts their confidence. What we do is, if a patient is strictly psychogenic, then initially we ask them to take 5 mg daily. Slowly, once they get confidence, slowly we'll decrease it to 2.5 mg, then 2.5 milligrams on alternate days, and then we stop this drug. So now tadalafil is also called as weekend drug. So why we call this as weekend drug is, sometimes once a patient takes tadalafil, it works for 24 to 36 hours. So now, one tablet of 10 milligrams or 20 milligrams on the weekend will give him good erections for next 2 to 3 days. That is why giving tadalafil is more flexible. You can give on daily doses or high doses or only on the weekends. So this is what I was discussing, selection of PDE5 inhibitors. If it is a psychological ED patient, then daily doses of tadalafil. Mild arteriogenic ED, then daily doses of tadalafil. Severe vasculogenic ED, then tadalafil may not help. Sometimes what we do is we put them on daily doses of tadalafil plus on-demand sildenafil or avenafil. And as I said, in couple with non-consummation of marriage, always start with high dose medication. In spite of having side effects, this is the only thing which can work for them. So these are the common side effects for PDE5 inhibitors: headache, flushing, dyspepsia, myalgia, back pain, nausea, nasal congestion, and visual disturbances. Visual disturbances are more common with sildenafil, but less with other drugs. And contraindications, coming to contraindications, all these PDE5 inhibitors are contraindicated if a patient is taking organic nitrates or if patient is having severe cardiac disease. So now, what if medical treatment fails? Then we have injection therapy. We give either we have trimix and bimix. It's a combination of alprostadil and pepaverin and chlorpheniramine. If chlorpheniramine maleate, it's not available, then we can only mix pepaverin and alprostadil, and this has to be directly injected into the cavernosa. Most of the patients will get very good erection, but only thing is pain, and the risk of priapism is on the higher side in these patients. So very rarely in only in non-drug responders, and sometimes patients with non-consummation, we use this drug. Sometimes when we give even high dose sildenafil, patients will come back saying that, doctor, I'm not able to maintain erection because of his anxiety. Here what we do is we give them this injection, and once we give this injection, erection will stay for 30 to 60 minutes. Then they can have intercourse. In spite of fear or performance anxiety, erection will not go down. That is the advantage with this intrapenile therapy. Coming to hormonal therapy, this is again important. Why this is important is, now most of the quacks, most of the alternative therapy medication people, what they do is, the moment they see a erectile dysfunction patient, they put them on high dose testosterone. This is which is totally contraindicated in young males. Hormonal therapy, if at all, if testosterone levels are on the lower side, it should not be direct testosterone. This has to be in different ways. This has to be in different ways. Then the next slide, I will tell you what medications can be given if there is low testosterone. And you have to look for abnormal T ratio while giving hormonal therapy. Coming to treatment options, we have clomiphene citrate, we have letrozole, anastrozole, gonadotropins, and testosterone injections. The last one should be avoided in patients who are trying to conceive. So first three medications are safe. Clomiphene citrate can be given for anybody, but this should not be on long term. There should be a gap after giving a course of 3 or 4 weeks of clomiphene citrate, and ideal doses for clomiphene is not 50 milligrams. It is 25 milligrams for males. After giving for a month, then you have to stop it for some time. Then you can restart. Otherwise, there will be abnormal TE ratio, and again, abnormal TE ratio itself can cause erectile dysfunction. And when it comes to letrozole or anastrozole, these medications are not for regular patients. Only when there is abnormal TE ratio, or people with obesity, high BMI, or chronic alcoholics where estrogen levels are on the higher side, this letrozole or anastrozole will help. And this should be given on alternate days, either anastrozole 1 milligrams or letrozole 2.5 milligrams on alternate days. And gonadotropins, if patient is not responding with clomiphene citrate, then you can put them on gonadotropins, HCG 5000 international units once a week for 4 to 6 weeks. Then you can check their testosterone levels. If testosterone level is still on the lower side, then you can continue these injections. But direct testosterone should be avoided in young males. So direct testosterone is available in 250 milligrams and 1000 milligrams. 250 milligrams is once in 3 weeks. 1000 milligrams is once in 10 to 12 weeks. Sometimes it works for 10 weeks. Sometimes it works for 12 weeks. That approximately once in 3 months, you can give direct testosterone. It's also available in patch and gel form. Oral medication is also available in tablet form, but you have to avoid testosterone in patients with prostate cancer or breast cancer. So now, what if medical treatment fails? Now, previously we used to think of surgical management. We used to do penile implant. Now we have a therapy called linear shockwave therapy. It works very well in if you select a patient in early vascular damage stage, then this is a wonderful therapy. But once the erectile dysfunction, severe arteriogenic ED sets in, and the peak systolic velocities during penile Doppler is very low, then this may not help. So this is ideal for patients in initial days. And even in patients with severe arterial damage, you can actually try it in a different way. Sometimes when we give patient, put them on medical treatment like sildenafil or high doses of sildenafil or tadalafil, if patient is not responding with these drugs, sometimes after this piezo wave therapy, they may respond to these medications, but they may not become totally normal with this piezo wave therapy. So that is why we divide these patients into two categories. One, young patients with mild arteriogenic ED who responds very well with this treatment. This is one set of patients. Most of these patients, first set of patients after piezo wave therapy, they may not require medical treatment. But only side effect with piezo wave therapy is a time-bound therapy. It works for a couple of months or years. Then again, patient has to undergo this therapy. In diabetics and hypertensives, it hardly works for 1 or 2 years. So because of their diabetes or hypertension, the vascularity keeps on damaging. So this is our paper paper which is published in Canadian Journal of Urology. This is on shockwave therapy. And now, what if everything fails? Then we have we have surgical management. There is nothing like impotency. Even patients who don't have erection during who haven't seen their erection during their lifetime, still we can make them normal with penile implant surgery. These are penile implants. What has to be done is we have to open the cavernosa. We have to take out those blood vessels, and we have to put these implants into the cavernosal cylinders. So now there are two cavernosal cylinders, and so we have to put two implants, and you can actually size them. These implants are available in various sizes and length and diameter. So you can actually select an implant for every patient. So according to their penile length and girth. So this is called malleable implant. This is also malleable implant, and this is inflatable implant. Inflatable, again, we have 2-piece and 3-piece. There is a reservoir here, and generally this is filled with saline. And whenever we press this, we put this reservoir in the scrotum, this pump in the scrotum. So whenever patient wants an erection, these are like balloons. Whenever patient wants an erection, he has to press this pump so that he gets an erection. And when he don't want, then he can press this button so that the fluid in the cylinder will go back to the cylinder. So this is how we give incision for the penile implant. This is called penoscrotal incision, and this is how we dilate the corporal cylinders. And after the penile implant, penile processes, this is how penis looks. Only problem is if patient is undergoing malleable processes, he will have erection. So now only thing is he should be in a position to bend this, or he has to concealing this implant. It might be little tricky situation, but apart from that, there are no long-term side effects. So thank you, doctors. These are the advantages of penile processes. One is low morbidity, low mortality, and success rates, very high success rates. And generally, if you compare with malleable processes, inflatable processes will give better patient satisfaction. But in India, inflatable implants are little expensive. That is why most of the patients, they undergo malleable processes. Thank you, Doctor.
Thank you, Rahul sir. Maybe request you to, there are so many queries, because if we solve all the queries now, then it will take so many times. So if you can
Yes.
answer all the queries in the chat box, it will save our time. So if it is
Okay,
convenient to you, please answer all the questions in the chat box. There are so many questions related to PD in the chat box. So,
Okay, sir.
yeah, thank you, sir. Lakshmi madam, your input.
No. Thank you so much, Dr. Rahul, for joining us and sharing your knowledge and experience with our dear delegates. Thank you on behalf of ICOG. Thank you.
Welcome.
Sama, unmute yourself. Sama, you are muted. Yeah.
Yes, sir. So I welcome our next speaker, Dr. Ajay N. Verghese. He is the founder chairman of International Association of Sexual Medicine Practitioners, Modern Medicine. He is director of ISRM, Institute of Sexual and Reproductive Medicine, Kozhikode. He has a tremendous experience in managing thousands of cases with various sexual dysfunctions. I welcome you, sir, to our FOGSI ICOG online certificate course. And sir shall be taking lecture on premature ejaculation. Over to you, sir.
Thank you for kind
Ajay,
introduction.
sir.
Okay. I am Dr. Ajay N. Verghese. I am based in Kerala, Calicut. I am chairman, International Association of Sexual Medicine Practitioners.
Jignesh, sir's PPT.
Yeah.
Sir,
Yeah.
you want us to run PPT?
Yeah, let me try to share it.
Okay, okay.
Is yeah. It is visible now?
No, not visible, sir.
Why is- Just a minute. I think. Oh, share the screen. I have to start. Is it visible now?
Oh,
No,
Yes.
no, not yet. Not yet, sir.
Not yet.
No. No problem. If you want, we can run PPT.
Oh, okay, please, please.
Jignesh,
Yes, sir.
please run the PPT.
Yes, sir.
ഇതില് ചാർജ് വരുന്നില്ല അതിന്റെ Is it okay?
1 minute, sir. 1 minute. 1 minute, sir. 1 minute.
make it full screen. Yeah. Yes.
Yes, sir.
I am Dr. Ajay N. Verghese. The introduction is already over. Then my topic is premature ejaculation, whether it is individual therapy or we need couple therapy. Actually, premature ejaculation, in the sense, it is not a disease. It is a condition. Normally, if you are going back to animal kingdom, there is no such an issue because of they don't need time at all. Then as far Homo sapiens are concerned, we need time because of sex is considered as an enjoyment. Okay. Next slide, please. Next slide. Okay. Premature ejaculation occurs when a man ejaculates before he or his partner wants climax to happen. Primary premature ejaculation, the problem starts with the first sexual experience. Secondary means it happens after a period of normal sexual functions. Next slide. Then taxonomy. It is onset is primary from the first sexual experience. Secondary means it is occurred. Then as far we are considering the time, whether it happens before vaginal penetration or during vaginal penetration. If it is occurring before vaginal penetration, it is considered as unconsummated marriage. Then what type, regarding the type, in all situations or in specific situations, comorbidities, no other sexual symptoms, all other things are all right. But in the other things is presence of other symptoms, example, erectile dysfunction may be there. Next slide. Estimated IELT, it's a approximate timing only. In USA, it is 13.6 for men, and a woman gets orgasm at 11.2. In UK, it is 9.9, and a woman gets orgasm at 8.5. In France, it is 9.3 minutes and 8.4. In Germany, see that red line. That means it is 6.9. Man ejaculates at 6.9 minutes and a woman needs 7.4 minutes. In Italy, it is 9.6 and a woman gets orgasm at 8.6 minutes. So now we can consider that in Germany, the problem is with the woman only, not with the male partner. Male partner is having 6.9 minutes. Even though orgasm will not be taking place from the female partner, because of it, she requires 7.4 minutes. Then 1 to 2 minutes is considered as short. That means we can consider it as premature ejaculation. 3 to 7 minutes it is adequate, and 7 to 13 minutes it is desirable. 13 to 30 minutes it is too long. Next slide. Then kindly note that in Germany, woman gets 7.4 minutes and men ejaculates at 6.9 minutes. Here, woman doesn't get sexual orgasm, but we cannot consider male partner to have any problem. Next slide. There is absolute premature ejaculation. Male partner is unable to penetrate, or within few seconds of ejaculation takes place. But in most cases, it is a couple issue. Our aim is to find, is it carpenter issue or it is the issue of wood or both. PME can be considered as couple issue in most cases. In my experience, as and when a patient comes and they complains of that premature ejaculation, I do counsel both of the partners. That means whether how long you are getting the time. That means intravaginal ejaculation. IELT. If you are asking in such a way, they will come that I am getting 5 minutes, 10 minutes. Then we have to ask the female partner whether she is anorgasmic or she is having any problem. Then premature ejaculation distress depends upon the mild or severe. 5.4 minutes is almost convenient for both partners. Then IELT less than 1 minute, it is definitely premature ejaculation. 1.5 minutes, probable premature ejaculation. Lifelong 1.5 minutes in 90% of intercourse. That is also considered as premature ejaculation. Acquired PE develops if it is 1.5 minutes. Next slide. Then neurophysiology, I am not going to explain it in detail. All of you know what is neurophysiology of ejaculation and everything. These all are theoretical parts. Next slide. Then here, one point I want to emphasize, that is serotonin is the most important neurochemical when we consider premature ejaculation. Next slide. Serotonin in the CNS inhibits the ejaculation reflex. With low CNS serotonin, ejaculation is not inhibited, setting the ejaculatory threshold at a lower point. Premature ejaculation seems to have neurological basis in some men. Next slide. Then investigations for premature ejaculation. Basic blood investigations are helpful. thyroid function test, total testosterone, prolactin, PSA, liver function test are mandatory. Penile biothesmiometry is also helpful. Next slide. Biothesmiometry is used in the diagnostics of peripheral neuropathies with impaired vibratory perception, threshold mainly in diabetology, neurology, and sexual medicine. Next slide. Next, treatment. There are, that means in previous days, where pharmacologically treatments are not available, drugs are not available. During that time, behavioral and psychosexual therapy was there. Stop-start method, skews method, these methods, even some psychologists as well as some sexual medicine practitioners use. Frankly speaking, I didn't have any good experience with this stop-start method or squeeze method. Patient and reverse counting such methods. Patient says that, sir, we are not getting any benefit from these things. Actually, nowadays, drug therapy will be better. Next slide. Then limitations of psychotherapy. Lack of independency. Therapy takes time to more time to be effective. Not applicable to all couples. Then good initially. Then finally it diminishes. Then more difficult to treat when not in stable relationship. Then time consuming and it is costly. Next slide. Topical anesthetics. Yes, topical anesthetic, that means lidocaine, prilocaine, all these things are useful. But the issue is that prolonged application of topical anesthetics may result in loss of erection due to numbness of the penis, and condom is required to avoid diffusion of the topical anesthetic agent into the vaginal wall, causing numbness in the partner. Normally, as and when a patient comes, we have to ask that. That means whether you are getting sufficient time at the second intercourse. That means suppose they have done an intercourse, they are getting 1 minute only. Then if you are doing intercourse after 30 minutes or 1 hour, if you are getting that sufficient time, then next thing is whether you are using condoms. When as and when you use condom, whether you are getting sufficient time. Then woman on top position, I do ask that also. These three questions. First of all, we have to ask them at the second attempt whether you are getting sufficient time. Then the second thing is whether as and when you are using condoms, whether you are getting sufficient time. The next thing is when you are woman on top position, are you satisfied? Whether you are getting sufficient time. Like this topical anesthetic is useful, but these are having some difficulties. Next slide. Then SSRIs are the best choice. That means naproxen and paroxetine are effective on demand basis. Off-label drug tramadol is also effective. Then the main advantage is that main disadvantage is that these drugs, all SSRIs, are causing erectile dysfunction. That's why continuously, suppose you are giving any type of erectile this thing, SSRI, that is fluoxetine or sertraline, or if you are giving like that continuously, if you are prescribing that, it will result in erectile dysfunction. Next slide. Why treat PD with pharmacological agent? Serotonin is considered as the key neurotransmitter involved in controlling the process of ejaculation. That's why we can use this sort of drugs. That means SSRI. Next slide. Couple therapy. If the male partner ejaculates after 5 minutes, suppose male partner gets 5 minutes, we must go for couple therapy, focusing the female partner. Next slide. How to select the couple for therapy? Proper data collection from the couple can help us whether it is individual problem or couple problem. If it is couple problem, absolute PME can be managed by individual therapy. If it is a couple problem, we have to go for couple counseling and couple treatment. Next slide. Then, instead of treating the male partner alone, we have to treat the female partner, or we have to start couple therapy. Next slide. If the male partner can attain 7 to 13 minutes, we can we have to include female partner also in the therapy. It is most important. Next slide. Can sexual orgasm or orgasm attained earlier by any method? There is no pharmacotherapy. Suppose we are one female partner is attaining orgasm within 10 minutes only. By pharmacologically, that means by giving any medicine, we cannot reduce this time. But there are some behavioral techniques. Next slide. Clitoral biothesmiometry. Clitoral biothesmiometer is a diagnostic as well as therapeutic equipment for low sexual desire, sexual arousal disorder, or orgasmic disorder can be treated with the clitoral biothesmiometry. And it is for our diagnostic purpose only. We cannot give this equipment to the patient. Okay. Next slide. Then there is considerable difference between male and female sexual drive. That means man only one switch is there. In woman, it is a complicated, several switches are there. That we must understand. Then let us go to next slide. Then by improving emotional independency, time for attaining sexual orgasm can be reduced. Improving emotional intimacy is a time-consuming process. Next slide. Methods to improve the emotional intimacy: promotion, non-sexual touch, sexual touch, clitoral and nipple stimulation, penetrate on demand only, valedictory. Okay, next slide. Then promotion. Women are different from men. Then ask what she needs to be happy and listen. Women typically need listening, not solutions. She is already competent. Never ask a woman to get into the point. Next slide. She needs time talking, and intimacy requires attention on her. Go for shopping with her. Go for picnic with her. Next slide. Then never feel that male partner is lying or cheating. Next slide. Then avoid pattern of bad relationship. She should not feel that you are ambivalent. No physical trauma. Next slide. Then praise her. The food you have prepared was so tasty. Like that, you have to, sometimes you have to lie also. Next slide. Then physical methods, non-sexual touch. This those who know sensory focus, they will be knowing about these things. Non-sexual touch, sexual touch. Non-sexual touch, her skin is 10 times more sensitive. Touching is a subtle, powerful, and complex form of communication. Correct touching helps to advance the relationship. Next slide. Then, where to touch? Start with light and brief touch in the arm to draw attention. Perform each touch at least twice before progressing to the next level of advance in the following order: hand squeeze, holding, brief knee touch, arm over the shoulder, progress to hugging. Next slide. Then touching gently on the toes and foot can improve the emotional intimacy because of genitals are very close to the big toe of the brain. Next slide. Non-sexual touch should continue for 1 to 2 weeks. If the tuning is perfect, go for sexual touch. Next slide. Sexual touch. Next slide. Clitoris and vagina. Start with the breast and the labium. Soft touch is beneficial. Duration 10 to 15 minutes. Then during this period, verbal communication is advocated. Next touch. Next slide. Simply rubbing the clitoris with one hand, palpating the breast with the other hand. Never do any painful activities. During this method, gradual mood elevation from the female partner can be seen. Check the vagina for lubrication. Next slide. Clitoral stimulation. Hold the clitoris with your 2 fingers. Stimulate it with the to and fro movement. Ask the patient whether you are being sexually excited. After completing this, check for the lubrication without putting the finger inside. If lubrication is there, it's a good sign. Next slide. If she feels comfortable, continue the clitoral stimulation. Now the male partner can penetrate the finger in the vagina and simulate hair. Next slide. Next slide. Then masturbating the clitoris with the one hand, palpating the breast with the other hand, hold the shaft of the clitoris with the thumb and index finger. Masturbate, ask how male do erection of as much males do. Erection of clitoris can be felt. Check the vagina for lubrication. Continue same process for some method. If the lubrication is present, partner can penetrate the finger inside and go for to and fro movements. Then finger insertion to the vagina can be done at the end of the stage if vagina is wet. Go for clitoral stimulation. Then penetrate on demand. If sexual arousal and sexual desire is achieved by the female partner, she will demand for the penetration. Then only penetrate, so that we can reduce the time of the female. By all these methods, we can reduce the time for attaining sexual orgasm in female. Thus, paradoxical premature ejaculation can be treated. Next slide. Then secondary premature ejaculation. If premature ejaculation occurs due to normal ejaculating male, it may be initial stage of developing an ED. That means as and when erectile dysfunction occurs, that's at the initial stage. Normally what happens, patient comes and patient complains that I am having erectile dysfunction. Then, I am having premature ejaculation. That means previously I was getting 10 minutes, now I am getting only 4 minutes, or previously I am getting 4 minutes, now I am getting only 2 minutes. This is at this point, we should consider that it is the erectile dysfunction, not premature ejaculation. Administration of PD5 inhibitors alone can treat this problem. That's why when a patient's complaint is premature ejaculation, we should consider that it may be erectile dysfunction or premature ejaculation. Mostly secondary premature ejaculation is due to erectile dysfunction only. Then prostate pathology is also there. By proper investigation, USG and PSA, we can understand whether prostate problem is there or not. Next slide. Many ED patients develop secondary premature ejaculation, specifically with the loss of sustaining capability to condition themselves to ejaculate rapidly in order to achieve orgasm before loss of erectile rigidity. ED should be treated first. Next slide. Chronic prostatitis. Chronic prostatitis is more prevalent among men with a diagnosis of PA. After 1 month of antibiotic treatment, most of the treated patients show significant increase in the IELT. Mechanism behind this link between chronic prostatitis and premature ejaculation and the mean by which antibiotic treatment improved IELT are not clear at all. Next slide. Surgical management. There are some surgical management, that is selective resection of branches of dorsal penile nerve. In some countries it is practiced, and they say that it increases the penile sensitivity and prolong IELT significantly. No definitive data, only some Asian countries reports are coming. And one more thing is there, the laser therapy is also advised. And I do not know how laser therapy can improve this premature ejaculation. But injecting botulinum into this particular nerve or bulbocavernous muscle can treat premature. Any questions?
Thank you, sir. Yeah, sir, there is one question. Women on top, why to ask? Hello. Hello.
Yes.
Yes, sir. There is one question you told about. We have to ask all the PE patients about women on top. Why that question? Sir, there.
I think he's having some network issues.
Okay, so we
I
will
see him. Yeah.
ask him to solve that query when search rejoin. No problem.
If he joins, he can answer in the chat box.
Yeah.
Yeah. Let's start with the third talk. Yeah.
Yes. Dr. Poonam, 1 minute.
Yes, sir.
1 minute. 1 minute. Let me share the CV. Yes. Yes, go ahead.
Yes. So good evening, everyone. I am here to invite our third speaker. She is Dr. Shaibia Saldana, and I am going to read a very special kind of this CV, because Shaibia Saldana started as an obstetrician and gynecologist, but is steadily evolving into a sexuality activist with a strong focus on child rights. While continuing her clinical practice of 25 years, she trains the stakeholders, medicos, counselors, police, lawyers, and judges, and the community at large in setting up child protection system in the state. Her childhood as an army daughter has stimulated her hobbies of trekking, traveling, and learning languages. She and her deep sea diver husband have 2 adult children who keep her grounded. That's very interesting sort of CV. So, Madam Shaibia, the screen is yours. You're most welcome.
Thank you so much. I'll just share my screen. Sorry, as always with these things, one is a little slow. Can you see it now?
Yes. Make it full screen. Yeah. Great. Great.
Thank you. So to start, adolescent sexuality is something which will take me 2 years to talk about. 30 minutes is so not enough. But I'd like to give a short brief about this. And what I will be talking about is basically cases that we've seen, which are common for us. Now, if you look at adolescence in, as per ICMR, is 10 to 19 years of age is what we call it. WHO calls youth as 15 to 24 years. One of the questions that were asked in the pre-test was, what is the commonest cause of death in adolescence? And basically you find that medically they don't have issues, health issues, very rare. The commonest cause of death is accidents, and the second is suicide. Why I wanted to bring this up was the fact that why do they have accidents is because of the risk-taking behavior, the need to break away from the childhood bonds of listen to parents, listen to school teachers, listen to society, and do something different. And invariably, whatever we tell them you shouldn't do is what they want to do, whether it's smoking, whether it's weed, whether it's driving a scooter without a helmet, or whether it's having sex. So the more we don't tell them about these things, the more chances they are that they are going to indulge in these. The other problem is suicide, and that's where I want to bring in the fact that this is a time of change, and so there are a lot of emotional crises which come up. And if you remember the last 2 days of sessions, in everything, wherever we are talking about any sort of sexual issues, we always spoke about socio-cultural issues and childhood issues, trauma in the childhood, confusion, and the way the family or the society has treated sexuality creates more confusion in the child.
Sorry to interrupt. Is it slide moving or there is a
No.
only?
No, it's not moving. I've kept it as is.
Slide. Okay. Okay.
Sure. So that is why it's very important that we look at adolescent sexuality. Surprisingly, earlier we thought that sexuality develops at the time of puberty. Then we realized it was from 5, 6, 7 years of age. But now we know that the concept of sexual identity, sexual understanding of oneself has started, what we call gender also, that understanding of oneself starts by the age of 2 years in young children. Now let's look at adolescent sexuality, and I'm going to, because it's such a vast subject, I'm going to take 3 cases and discuss it under these. Now, first thing is, how does this child come to us? How does this adolescent present in the clinic? So the first way that happens is dragged in by the parents. I think all of you have seen so many young teenagers, for the gynecologists, the young women, girls being brought into your clinic. And one of the ways this happened for me was the first case of this 14-year-old girl brought by her parents, caught in school kissing a girl classmate in the bathroom. The parents were called by the school and told that she will be expelled. They were horrified, upset, embarrassed, didn't know what to do. And the child kept insisting that she hadn't done anything wrong. She said, I haven't done anything wrong. I like her. She's my girlfriend. And that, of course, beyond just kissing a classmate in the bathroom, or the kissing issue, was the issue of what was she trying to say that she had a girlfriend. Now, how would you like to handle this? What would you like to say or do? And the first thing would be reassurance and a respectful listening to the parents and the child. So without in any way negating either of the two, like when the parents are saying, why is she doing this? What is wrong with her? Please tell her this is not okay. You talk to the parents and ask, what are the issues that happened? How did it happen? Give them reassurance. And then we give them information. And with the information, an offer of help and support. And in these cases, I do believe that counseling has a huge area. And while as gynecologists, we do counsel, I think what we do is give anticipatory guidance. What is counseling is very specifically a psychotherapist area of expertise. So what I do is I often use this, the gender-bread person. The gender-bread person is my way of talking to young people who come to me with a confusion or questions about their identity. Now, the gender-bread person is about what is one's identity, one's attractions, one's biological anatomical sex, and the expression of it. So if you look at the gender-bread person again, what we see is the first is the biological sex. Now, this biological sex is what we see as doctors when a child delivers and we say, oh, it's a boy, because we've seen a penis and testes. Or we say, oh, it's a girl, because we see the vagina. And sometimes we see a child who's intersex. So we say, I'm sorry, we can't tell you whether it's a boy or a girl. And then we get into this concern about what do we tell the parents? Should we do a chromosomal assessment immediately? What do we say to the child? And sadly enough, the gender identity, which will come up in a few years, by 2, 3, 4, definitely, would have told us what this child is. And so sometimes nowadays, what I've started doing is when people say after the delivery, when I bring the baby out to show the parents and I say, they'll say, what is it, doctor? Is it a boy or a girl? I say, anatomically, the child is a boy, or anatomically, the child is a girl. But gender is something that develops slowly, and the child will tell us over the years who they are. And so a small little seed of support to the child is started here in case the child has a gender which is different from their own biological anatomical sex. The next thing we talk about is gender identity, which is the child's own feeling. And this starts by 2, 3, 4. The child was feeling about whether I am a woman, a man, I'm neither, or I am both. That becomes very important over here. So some people say, I'm gender fluid. I don't feel a boy or a girl. I could be both. Another says, I'm gender neutral. I don't really know. I don't want to label myself as a boy, as a girl. And as we see, because of much more, exposure to TV serials, movies, newspapers, WhatsApp, the children are aware of these things. So they start questioning it. And then there is the gender expression. Who I want to be to others. Do I want to cut my hair short? Do I keep my hair long? Do I wear makeup? Do I have my hair long? Do I wear earrings? Do I not? These are all exploratory processes of a young person. The next part is the attraction. So we were talking of the identity, which is in the brain. We talk of the expression, and we talk of the anatomic sex. Now we talk about the attractions. There is the sexual attractions. Now here, the sexual attraction is very much a paradigm in the sense, it's not either male or female. Who am I sexually attracted to? The person may be attracted to women in some ways, to men, to both. So you could be heterosexual, you could be homosexual, you could be bisexual, you could be asexual, not attracted at all. There are some people who say, I'm very romantically interested in this person. I want to write poetry. I want to talk about them. I want to talk about love, but I don't want to do sex. I don't want physical touch. There's romantic attraction. Then we have things like demisexual. Demisexual means somebody who is attracted only after they are emotionally involved with a person. You have sapiosexual, which is being attracted to the intelligence of a person. So if a person is not apparently the sort of intelligence that this person wants, they won't feel it. So I use the gender-bread person to often explain to young people and their families what exactly is happening in our bodies. So this is the way that I would go ahead with this young child, talking about what is there, and most importantly, telling the child that whatever you feel is okay. There is nothing wrong. And here sometimes I may talk separately to the child as compared to the parents, may ask the parents to step up. So I can talk to the child to get a deeper sense of what is happening. So one was how the child comes in, dragged in by the parents. The next one is where the child is accompanied by the parents. That means both the child and the parents feel there is some sort of an issue, but they don't know how to handle it. Now, in this case, I had a girl who was 17 years old. She came in with her parents. Now she is overweight, around 96 kilos. And I would like to say, I don't like the word obese. I find it pejorative and disrespectful. Overweight is overweight. It could be extremely overweight. The person already knows. So just calling them obese is just putting them down. Now she has had occasional irregular periods, mild acne, but no facial hirsutism. And she has a previous scan done a couple of years earlier, which showed PCOS-like morphology. So now what do we do? For all of us, it will be immediately like, oh, this is PCO. Her parents and she want treatment. Now, in this case, we go through the same processes again. What do I say or do? First, I listen to all the symptoms, all the concerns. And very often the parents say things like, you know, doctor, she's been told, please take off weight, please do this, please do that. She's not doing any of these things. It's very difficult for us. We really want her to get well, but you know, she starts exercise, she goes to the gym and it stops. What do we do? A very detailed history taking is important. And then we give information. Now, as all of you know, as gynecologists, there are 4 times in a woman's life when there are severe changes which occur. That is from birth to about 3 to 4 years of age, when the child grows from a very small, completely sort of a dependent baby to a 3 or 4 year old who's talking, walking, moving. The amount of brain development that's occurred is huge. So the second time this happens is during the teenage years, when a child becomes an adult, then entire body shifts through adolescence. The third time is during the first 3 months of pregnancy, when a woman goes from a non-pregnant state into a pregnant state. So entire physiology, mental and emotional state, like Dr. Radwa mentioned yesterday, changes completely. And the fourth place is menopause, where a woman moves from a reproductive age group into a non-reproductive age group. So one of the most important things which happen at these times, 3 times, 4 times, when the body changes a lot, is you need a lot of sleep, you need minimum stress, you need good, healthy nutrition, you need regular meals, and you need an environment which is conducive to these changes. Now look at the teenage levels. The most important thing I would say, the information I give very many parents is that, and you will find out, they will say class 8, 9, 10, the child put on weight. Class 11, 12, she's put on weight. Just before her exam, she put on weight. When she went into college the first year, she put on weight. Before that, she was fine. And you will find that this happens because we as a society actively cause harm to the young child. We say, stop going for dance classes, stop going out with anybody else, don't go for your cricket, your hockey, your football, don't play games, don't go swimming, you have to study. We wake them up at 5 o'clock in the morning for their tuition classes and they sit with homework till 12, 1 o'clock at night. Their sleep is affected. Is there a hand raised by Dr. Arjun? Anybody? Okay.
No, we will take any question at the end.
Sure. So these are the issues which come up. Then on top of that, food. Now, the child has to run at 7:30, 8 o'clock in the morning, and it's very difficult to eat a meal when you've not had an incomplete sleep. So we pour milk down their throats, drink milk. Now, milk is very filling, but is 90% water and 10% everything else like proteins and calcium and things like that. It doesn't work. We do find that a good protein meal, a boiled egg, a paneer roti, some sabzi is much better than giving just a carbohydrate breakfast in the morning. And sometimes you'll find these children don't feel like eating in the after morning, but they will eat at 10:30. So giving a protein meal at 10:30 for the time of the short break, where often we give chips or biscuits or something much milder or just fruit. Fruit is good, but not sufficient. Then, of course, their meals become changed because they're running around crazily. Another thing that parents do is because we are forcing them to study like this, we try to pamper them a lot. And I don't blame children for eating junk food. They didn't go to the shop to buy junk food. They learned of it from the ads in the papers, from the ads on TV and WhatsApp, and from what the family brings. I remember one of the children once asked, you say that chocolates are bad for me and carrots and beans are good for me. Then why when I do something well, when I get good marks in my exams, you give me chocolates and not vegetables? And that in a way is the paradox that parents create for their kids. So what I find that is what I would call temporary PCO or an education system created PCO, which is about not enough sleep, no exercise. We stop them walking with their friends. All of us, I think, when we were young, we would walk for miles with our friends after school, chatting and moving. There was so much physical activity. We stopped that. No, come home immediately. The world is unsafe. Don't stay there. Go by school bus. Sit in the school bus. Sit in class. Come back again. All these things cause an effect. So I believe that it's very important that we give the information about what is the reason why this PCO-like system is coming up. And then you offer your help and support. In which way? Please don't say lose weight. One of the worst things one can do is tell a young girl, lose weight. Please don't ask for diets and food. Don't eat chips, don't eat chocolates, don't eat sweets. Eat healthy vegetables, eat healthy fruits. And then you tell the child, you need exercise. And what the parents do is this becomes a sort of weapon in the parents' hands to make them exercise. And you will find that it's very difficult. Please understand weight is an emotional and a psychosexual issue too. We have found that if there is childhood trauma, if there is a lot of marital discord between the parents, if the parents themselves are going through issues of, say, financial issues, or there are grandparents in the house, there is stress and strain in the house, if the child themselves are going through questions on their own sexuality, on their own identity, if the parents are very determined on good academic performance and the child would like to go for arts, would like to go to the humanities, all these issues. If there is a lot of comparison in the house, oh, your sister sings so beautifully, what's wrong with you? Oh, your brother gets such good marks, why don't you study? Oh, look at your sister or brother, they get up so fast, they get up early, they're such good children, what is wrong with you? All these things are physical, emotional abuse, which affects the child. And one of the ways they say is that weight is a way we cover our body to protect ourselves. I would strongly suggest, instead of saying lose weight, giving diets, exercise, help the child to meet a counselor who will be able to help guide the child into an effective way of seeing what's happening in their lives. That would be more effective. The next thing which comes up then is the third person. Who is the person brought by this child? The child is brought by a friend or walked in by themselves. Now, this is wonderful, I would say, for a gynecologist, because if they're brought by a friend, the friend says, you know, I came to you so many years ago and I really like the way you spoke, so I have brought my friend. And if they walk in by themselves, they have come there willing to trust you. And I think it's so important that we acknowledge that we are being trusted and we live up to the trust that they give us. And this, I would like to talk about this 19-year-old girl who came into my OPD. She was nervous, she was embarrassed. She came all by herself and she said, I got your number and name from my friend in my college. She said, you'll be able to help me. She was willing to trust, but she was scared. She told me that she had gone for a post-exam class party. She drank some beer. And then she was offered a drop home by her classmate. Her parents happened to be out. They had gone out for a dinner too, so they were not at home. So he came in for a bit and sat down and they were chatting. They were kissing on the sofa, but he started getting more intimate. She didn't mind the kissing, but when he started getting more intimate, and when she objected and tried to push him away, he became aggressive and forced himself on her. It was rape. She said that she froze. She could not say anything, could not do anything. And he got up and he left. And when we talk of stress reaction to some sort of an attack, we talk of flight or fright. But there is another angle which is called freezing. And it often happens to many of you would have noticed if your bag or wallet was suddenly snatched somewhere or somebody suddenly attacked you, you don't have the time to react. Your brain just freezes. And that often happens in the case of a sexual assault. The girl got up and went into her room and locked herself in. In the morning, she was behaving completely normally. She actually heard her parents coming in, but she didn't want to step out and talk to them. She did not sleep all night. When she got up and came out, she was behaving normally, but her parents did ask, is everything okay? Because she was looking a little low. They could sense there was something not okay. And she said, no, the party was very long. We came home, it was late. You know, children can prevaricate and they can often convince you there's nothing wrong when there is something seriously wrong. What would one say or do in this case? The first thing is reassurance. I'm sad to say that very often, and though that is changing nowadays, that sometimes as gynecologists, we are very disrespectful. So why did you drink? Why did you let him come inside the house? You know it's not okay to drink. You're underage. You shouldn't have been drinking. These are things we often say, and they're not respectful. We need to listen out to everything the child is saying because she has come with a willingness to trust us, and we really need to deserve the trust. The next is information. For this child, I said, I am so grateful that you came to meet me. It is very important to speak to somebody about what happened to you, and it was not your fault. And besides offering, I say very strongly, many, many times in that consultation, I told her, it was not your fault. You did not ask for it. Drinking alcohol, going for a party, calling a friend home who you trusted, kissing a boy is not asking for it. You have not asked for it because it is what is called consent and respect for yourself. So I spoke to her about these things and I said, I really want you to understand that it was not your fault. And also for a lot of these girls, unfortunately, because of the socio-cultural system we belong to, if she has not had sex before or any sexual activity, she believes that she is ruined, she's spoiled. And that's where I explain the anatomy of things to her and explain. And when I would examine her, I would see whether she had any pain, any trauma, and she cuts. And I would tell her, just like if you fell down from a cycle, or if you're walking on the road and some idiot irresponsibly bashed into you with a scooter, you fell down, you got hurt, you broke your arm, you scratched yourself, but you're not the scooter accident case forever. You're not a broken arm and bruises forever. You will heal, and at some time your arm will be fine, your bones will be healed. Yes, for some time you will feel fear that, oh, when I hear a scooter, it makes me scared. Similarly, your body will heal, your vagina will heal, your parts of your body, the pain will go away. You have lost trust, and that will take time to come back again. But it does not mean that you are not a whole and complete human being, that you can go ahead in your life. You will find somebody you trust, a partner you can trust and have a wonderful relationship with. You can have an extremely liberating sexual relationship with somebody. You can have emotional well-being. You can have a career. Your life does not stop with this one incident. I also ask, do you have somebody you can speak to? It would be great if it was parents, but unfortunately, very often parents are not the people a child will say this to. So an elder sister, brother, a sibling, an aunt, a friend, an older friend, a friend's mother, a teacher. These are all the people we call trusted adults, where we ask, try and see if you can speak to somebody because it will give you support. So as a summary, if you look at all these cases, what issues do adolescents come for? I would also mention in the previous slide that after examining the patient, I would also find out if she wants to take police thing. Now, in this case, it's a boyfriend, and we all know that is when it's intrafamilial sexual assault, or if it's a date rape, the child very rarely wants to take action. In case the child says, I do want to take action, and this is 19, so I don't come under FOGSI. If she was under 18, I would have to report it under FOGSI. Since she is over 19, I can ask her what she wants to do. I can take slides. I can do the examination as per FOGSI, do swabs, take swabs and keep it, and say that I will keep it for some time. And if you want to report it, the material will be here. I will also talk to her about the risk of a sexually transmitted disease. If she has any discharge, any infection, I would like her to come back to me. I would suggest if she's very worried or she is not sure whether the boyfriend has had many sexual relationships, I would suggest an HIV, hepatitis B, VDRL test, hepatitis C test after 6 weeks. And I would definitely give her emergency contraceptive. If I don't give it, that's inadequate medical care on my part, because there is an 8% risk with a single act of unprotected sexual intercourse, of risk of pregnancy with unprotected intercourse. So giving her an eye pill or an unwanted pregnancy emergency contraceptive is very important. Now, if you look at what issues do adolescents come for, they come for gender identity. So you will have young people saying, I don't know, I'm a boy or a girl. And very often either they come directly or they come with a question from others, or they are brought by their family because they are behaving, for girls, they're behaving in a masculine manner, or they don't want to behave in a typical girl's, expression of feminine or female manner. Sexual orientation is very important. I find a lot of young people come to me and tell me, I'm bisexual. And I'm like, okay, I'm happy to know that. And why do you think you're bisexual? And they will say, well, and they're not very sure when they're saying they're bisexual. They say, well, especially when they're 14, 15, 16, they'll say, well, I think I'm attracted to girls and boys. And I'm like, yes. So when you're growing, your hormones are growing and developing. And so sexual attraction is normal because your body is becoming an adult. And a job of an adult is to reproduce. So one of the parts is to be attracted. So being sexually attracted is perfectly normal. It's very healthy. But you will have an idea, what is my orientation? Who am I? These are questions which you are answering. And your answers will come to you if you think over them, discuss it with your friends. You don't have to label yourself as bisexual, heterosexual, homosexual, asexual. It will come to you and you can take action, and none of it is wrong. All of them is within the norms of what we consider sexual orientation and gender identity. Then they have sexual doubts and misconceptions. And I think the last 2 days we were talking about that, right? That, children have come with worries about, is it sex very painful? Or if I kiss a boy or sit next to him, will I become pregnant? And this comes from the socio-cultural issues. For girls, a huge amount of issues come from the way periods are treated in the family. For families where the girls are told, oh, periods are normal, don't worry, jump, run, do everything, be active. There's a difference. For those who are told, be careful, Don't jump around too much. Oh my God, you started your periods at 10. How sad for you. These are all things which impact children. Or now you started your periods, behave yourself. Don't go out with boys. Be careful. These are things which affect a child's psyche. They create fear. They create anxiety. Body image. And this is very much at the door of our media, but also families. Oh, you're so dark. You're so thin. You're so fat. Oh, you got specs. Oh, look at your body structure. You know, you have to stand with your shoulders straight. Don't slouch. These are all comments which affect the body. And these are things that as gynecologists, it's important we talk to parents not to mention it. And then trauma. It is very important that we look at trauma-informed care for our children. Traumas can be many ways. And I think all of you have heard of the adverse childhood experiences. There are 10 of them. And any child, especially below the age of 6, but even older, if they have gone through a loss of a parent, separation of the parents, divorce of a parents, separation from the primary caregiver in the young age, if either of the parents have a mental health issue, if either of the parents if they are violent, if there is physical trauma at home, and I'm sorry to say, parents hitting children is physical trauma. There is no question of discipline. Emotional trauma, as I mentioned, was about comparisons compared to other siblings, cousins, to other people in school. All these things cause trauma. And of course, sexual abuse. Sexual abuse is only one of the traumas. And it is important sometimes to ask it. So sometimes I ask children, if I have a doubt in a young patient, maybe 14, 15, or even older, or even one of my adult gynecology patients, I say, I'm going to ask you a couple of personal questions. They may be embarrassing for you to answer, and you may not wish to answer them, whether the answer is yes or no. So you can take a pass. So I will ask you some questions. You're free to answer them. And if you don't want to answer them, irrespective of the answer, you just say, I pass that question. That's when I ask them about adverse childhood experiences. I say, were you touched in a way which was uncomfortable? Were you ever hit in a way which was uncomfortable? Were you ever sexually touched? Did someone try to touch you in a way in your genitals or your body in a way that was uncomfortable, which made you feel scared? And all these things, and they have the right to say yes or no, or just a pass. Till today, I have never had any patient who has refused to answer because they have answered, yes, I have been sexually abused, or they have said, well, somebody did touch me, or in buses and all that, I've been touched. You know how it is, ma'am. But no, I have not been sexually abused. And the biggest issue is health issues masquerading as any of the above. And that is very important. I have 2 minutes left, I think. Health issues masquerading as any of the above. So if a child comes with chronic pain, chronic vaginal itching, chronic vaginal discharge, if they come with breast pain, I've had young people coming, 17, 18-year-olds saying, can you cut off my breasts? I hate them. Can you remove my uterus? I don't want my uterus. It's so painful. And very often painful periods, breast pain comes from women who have been taught in their families that being a woman is bad news for the family, or being a woman means you are less than others. Now, how do you prevent this young adolescent from running away from your OPD? Acknowledge their presence. Thank you for coming. I'm so glad you came. I feel really good that you trusted me enough to come and talk to me. Direct your questions to them. So if the parents are there and they say, I want to talk about my child, I talk to the child. I thank the parents. I say, thank you. May I talk to her? What name would you like me to call you by? How old are you? Which school or college do you go to? What are you studying at present? What are your favorite subjects? Something non-threatening, relaxing questions. Then, once I am sure that the child does not have an intellectual disability, when the child I feel is comfortable enough with me that I can handle the child, because there can be some children who are deeply emotionally disturbed and you cannot ask the parents to go out. But in these cases, I would say, would you like your parents to step out for a while? And I smile at the parents and say, if you don't mind. Parents rarely do. And the child says yes. Sometimes a child just looks at you like this and you can make out that the child wants them to go, but is too scared to say so. And I tell the parents, if you don't mind, would you sit out for a little while? I'll call you back in again. And sometimes the child says, no, it's okay if my mother stays here. It's fine. That works fine. There is complete freedom for the child to decide what they want. So this is what is called gender affirmative and sex positive practice. This is what I would like for me to have in my clinic, establishing a safe place where I take the consent of a young adolescent who has come to my clinic. I talk about confidentiality. I tell the young person when they're there with me that whatever they say is confidential. But I also mention that, if I feel you may be harming yourself or there is something where something is worrying you very deeply, I will ask your permission, but I may share it. But otherwise, everything else, whether you have your sexual identity, anything, any sexual, experiences you had, everything else without your permission, I am not going to speak about it to your parents. And that is how I respect the person. Our words are very important, clear communication. So talk of penis and vagina, talk about masturbation. Do you feel sexually excited? Are you intimate? Have you had intimate relationships with anybody? Use the words with respect, with clarity, and without judgment. A non-judgmental attitude and trauma-informed care. Understanding that a child who freezes when they're talking or just looks at you and doesn't answer a question, don't ask the question again. Say, I know you're feeling uncomfortable with this question. Let's go to some other question. We'll come back to this later. If you want to talk about it, we can also talk about it next time. And then we can also speak about, sometimes I talk about the fact that I have spoken to many young children who have suffered from sexual abuse. And I tell them, these things affect us. They make us feel bad about our bodies. But sex is a great thing. Sexual abuse is not your fault. And you can have, and it's okay to have sex when you want to. And it's not right for anybody to have sex with you if you didn't wish it. I ask open questions. And one of them I ask is, what pronoun do you use for yourself? So I will say, do you count yourself as he or she or they? And nowadays, young people, especially when I'm in Bangalore, they will say, I say they or he or she. But just the fact that you ask that, I ask them, would you like to tell me what you feel about sex or about someone trying to force you or about boyfriends or girlfriends? Did you know that? And that's when I give them the information, whether it's the gingerbread man or whether it's the, conversations about sex, about safety in sex, that sex is beautiful, sex is lovely, but there has to be an age at which we should take it on. What is the age for which is right for us to have sex? Depends on each person. There is nothing which is common. Finally, that is the end. Thank you so much. I think I've just finished my time.
Yes, on very much time.
Questions?
Thank you, Dr. Sabya. It was a very eye-opening and very sensitive issue. You spoke so well about that, everything.
Thank you. Thank you. Are there any questions?
Madam, are you there?
Yes, I am very much here. And Dr. Shaiba, it was really eye-opener, not only for me as a gynecologist, but as a mother also. And you have really touched that how we all should be so compassionate, because it invariably happens that we also start preaching in our OPD. And I am really touched by your the way you managed that overweight case. I will also not use the word obesity, because we do get many cases of PCOS and we are in the habit of, okay, change your diet, don't eat junk food. I mean, it happens. So I think each and every gynecologist or each and every mother, father who is here, we have to really change our mindset, and so much mental block and prejudice is there. So it was a wonderful, wonderful talk, Dr. Shaiba, and I'm really touched by your talk that we all have to be so compassionate towards these adolescents. So thank you so much for this wonderful talk.
I just wanted to mention that I belong to Enfold Trust, and www.enfoldindia.org has a lot of material on it on the website on how to talk to children. So some of the parents who come to you, you can just give it to them, and there is a lot of in different languages also. So anybody who wants can just, utilize it.
Great, great. Thank you so much. Neeraj,
So much admiration is there in the chat box. Everyone is so happy, ma'am. You will have to go through all those comments and many questions. Few questions are also there. So please just have a look. And we are so happy that everyone is very happy. And one question was there that if somebody needs any training to talk to the clients as you do, the way you talk to your clients, that's super. So, Neeraj,
There's a
sir?
this thing by Enfold. Enfold has a talk called Demystifying Sexuality, where we train doctors, parents, school teachers, counselors on how to do sexuality education, how to talk to children about these things, and it's there.
Great, great.
So, sir, should we move ahead?
Yes, yes, please.
Yeah.
Thank
So
you.
the next speaker is our eminent speaker is Dr. Sunil Jindal, sir. Welcome, sir. Sir is a consultant andrologist and a scientific director, Jindal Hospital and Fertility Center, vice chairperson, Delhi ISAR, Delhi IAGE. And he has got so many gold medals and he's an awardee of many awards, and he is a star actually. He has got many publications and presentations, and you will you all know about him, and you will see his presentation and his deliberation. Sir, you are most welcome. The screen is waiting for you.
Thank you very much. Thank you very much. Can you hear me loud and clear?
Yes.
Can you hear me? Yeah. So thank you very much. So the first thing is I would like to thank Dr. Neeraj. He's brought sex from the bedroom into the clinics of every gynecologist. Thank you very much. Thank you, Dr. Srikhande, Dr. Purva, for organizing this amazing program where you actually are bringing across such a useful thing to the clinic of every gynecologist, because the last lecture before this was amazing. It had so much of compassion, so much of empathy, which these patients need. Thank you for this program. And today, Dr. Neeraj has given me a topic: sexual dysfunction in non-communicable diseases. He always gives me a topic which I sometimes feel, my goodness, what do I talk in it? But then I realized that in the fertility practice which I have, which also has a lot of, I would say, sexual dysfunction, and I get a lot of patients of sexual dysfunction, a very big portion of their sexual dysfunction is the non-communicable diseases they have. And unfortunately, whether they go to a diabetologist, whether they go to a cardiologist, none of them even ask them a question about their sexual dysfunction. So it's not only gynecologists who need to be trained. I think one field which needs to be trained is internists and cardiologists, because they need to be a part of the system. You'll be surprised to know that in case a man in his 40s has erectile dysfunction, the chances that he is going to have a cardiac arrest or a cardiac attack in the next 4 years is 4 times more. And this is very pertinent. So I'll just start sharing my slides. So let's begin with the fact that sexual dysfunction is common, distressing, especially in non-communicable disease. And the World Health Organization says that 71% of deaths in 2016 due to these chronic conditions include cardiovascular disease, diabetes, obesity, and cancer. And do you know?
Sorry to interrupt. 1 minute. Okay.
Can I continue?
Absolutely. Go ahead.
Yeah. So something to be understood is the multiple phases of sexual response. And most of the problems in NCD is in erectile dysfunction, low libido, and orgasmic disorders. And the prevalence and impact of these sexual dysfunctions is something I'm going to talk about. And why is it important to address these sexual issues is because we all need a holistic approach towards this patient. Now, according to a study, the prevalence of sexual dysfunction in individuals with NCD ranges from 35% to 90%. Now, I'll talk to you about a patient. Now, this gentleman came to me, and this gentleman's wife had had a malignancy. Post-malignancy, she was cured, and it had been post-malignancy treatment about 5 years. And he came to me and he said something. He said, from the time she has had malignancy, our life has changed. So I understood and I said, well, I can understand your life has changed, but now she's fine and she's post 5 years. For all we know, she's cured, and I think you should be happy. And he says, we have not had sexual intercourse for the last 6 years. And I think I have erectile dysfunction. This is the kind of issues which people, even in the intimacy, face if malignancy has been there. And this, nobody till date had addressed this issue to this man or to his wife. Now, what is the association between NCD and sexual dysfunction? There is a common mechanism underlying sexual dysfunction in NCD, and there are shared risk factors contributing to both. So if somebody has a cardiac problem, he also will have erectile dysfunction. If somebody has hypertension, he may also have erectile dysfunction. If a woman has malignancy, she may have an orgasmic or a hypoactive sexual disorder. And if there is chronic pain, there is bound to have hypoactive sexual disorder. Now, approximately 40% of patients with hypertension experience erectile dysfunction. This is a beautiful study which was done in 2017, and it's in the Journal of Sexual Medicine. And can you imagine that 40% of people with blood pressure have erectile dysfunction? The number of tablets which are sold of hypertension in this country and worldwide, if you take out 40% of them, you will realize that the most prevalent epidemic in the world is sexual dysfunction. Sexual dysfunction affects 40 to 70% of individuals with cardiovascular disease. So 40 to 70% have either had a cardiovascular disease or they are bound to have a cardiovascular disease in the near future. So if somebody comes with erectile dysfunction to you, get a cardiac checkup done if he's young. And the prevalence of sexual dysfunction in patients with obesity is between 50 and 70%. Can you imagine that in those people who are overweight, where obesity is there, you have sexual dysfunction in 50 to 70%. Now let's come to diabetes. Diabetes leads to nerve damage, reduces blood flow, and also causes hormonal imbalance. So diabetes is something which affects all the three things. It can lead to neural damage. It, of course, leads to atherosclerosis, and it also compromises the hormones. The importance of diabetic control in these patients is just a part of it. So I do not know how many diabetologists actually ask their patients if they have sexual dysfunction. But if you ask me, a part of their history needs to be sexual dysfunction. So studies suggest that sexual dysfunction affects up to 90% of individuals with diabetes. Most of the patients post 50 years with hypertension taking metoprolol or a beta blocker, along with that, they would normally, if they have diabetes, they would also have sexual dysfunction. It's a very interesting thing that in those men who have sleep apnea, most of the men are obese, most of these men have low testosterone, and most of these people have sexual dysfunction. I have never heard a respiratory specialist ever talk about sexual dysfunction in sleep apnea. They should. So hypertension is a vascular disease, impairs blood flow, and contributes to sexual dysfunction. And there is a direct relationship between hypertension, cardiovascular disease, and sexual dysfunction. And on top of it, when these men have antihypertensive medication, it contributes further. Lifestyle modifications which they are taught are helpful for the cardiac, hypertensive, as well as the sexual issues. So erectile dysfunction is prevalent, as I said before, in 40% of patients with hypertension. And sexual dysfunction is common among individuals with cardiovascular disease in up to 40 to 70%. Obesity. Now, what does obesity do? It does something very interesting in the man. This fat converts testosterone into estrogen. And not only that, it also leads to a metabolic syndrome. And along with that, it, along with hormonal, also leads to physical incapacitation. So the effect of weight loss and lifestyle intervention on sexual function is phenomenal. It is also very important in diabetics. And the psychological aspect and the body image also concerns them. So you have a woman who is overweight, and in that state, she doesn't want to take off her clothes. She becomes hypoactive, sexually disordered. There is a man who, because of his great obesity, feels his penis is too small and he's incapable of having sex. And a lot of times you have a couple, both of whom are obese, and at that time, apart from the hormonal problem, there is also an anatomical problem because of which the problem may happen. However, lifestyle and weight loss helps greatly in the position and in these patients who are obese and in obesity. So in obesity, lifestyle modification and weight loss becomes extremely important. Now, the prevalence of sexual dysfunction in individuals with obesity ranges from 50% to 75%. So these men have, of course, low testosterone. They have sleep apnea. Because of the sleep apnea, the sleep goes down, and going down of the sleep cycle decreases testosterone further, and they go into a state of sexual dysfunction. So medications used for management of NCDs also have side effects. So एक तो इन बेचारों को डायबिटीज ने मार रखा है, हाइपरटेंशन ने मार रखा है, फिर डॉक्टर ने ये तो पूछा नहीं कि आपको कोई सेक्सुअल प्रॉब्लम है क्या, and they would write a drug, the side effects of which is going to be sexual dysfunction. So the importance of open communication between the patient and the healthcare provider is very, very pertinent and important. Now, certain antihypertensives such as beta blockers and diuretics are associated with sexual side effects, including erectile dysfunction. We all know that. And a lot of these obese patients who have depression, they take SSRIs. And these are commonly used to treat depression, and these lead to sexual dysfunction. The sexual dysfunction leads to further depression. Then there is sexual dysfunction and depression, and becomes a circle. And it needs to be treated. Those psychological factors can be present as stress, anxiety, depression, and all these things contribute to sexual dysfunction. It's very important to understand the bidirectional relationship between mental health and sexual health and the sexual function. Screening and addressing psychological factors in management is important, and a multidisciplinary approach is important. Most of the people, including me, just do not have the time to sit down and counsel. And even if I counsel for some time, there is a psychotherapist, a psychologist, which is needed for this. Now, studies have shown that the relationship between mental health and sexual function with psychological factors play a significant role in sexual dysfunction. Now, chronic pain. People with arthritis, people with back pain, do you think they can have sex? They're so bothered with their pain from the morning, they get up in the morning till evening, that it just leads to sexual dysfunction. And holistic pain management approach should be such that it addresses the physical, the emotional, the mental, and the sexual function. Now, chronic pain can lead to reduced sexual desire, arousal, and satisfaction, which is very clear. So I've spoken to you about diabetes. I've spoken to you about hypertension. I've spoken to you about obesity. I've spoken to you about chronic pain. But age leads to hormonal imbalance and can contribute to sexual dysfunction. Though age is not a non-communicable disease, it's communicable. It's not communicable at all. But most of these diseases get compounded when there is sexual dysfunction. And aging leads to increase in diabetes, increase in hypertension, increase in hormonal changes. And hormonal replacement therapy, especially in women, can do magic in managing dysfunction, sexual dysfunction. And there is a very important thing for people to sit down, counsel, and understand this. And they need to be treated. They need treatment. So the social and cultural influence, of course, is very wide. I get so many patients who say, "Ab hamare bacche ho gaye, 40 saal ho gaye, ab sex ko kya karenge?" And the man says, "Ye bilkul sex karne ke liye taiyar nahi hai. She just would not agree for any kind of sex." Though she has a hypoactive sexual disorder, she says it's normal because she's asked all her friends, and except for a few who are too fast, nobody has sex. So these kind of beliefs and attitudes lead to problems and compound NCDs to have these problems further on. Now, I have spoken about how cardiovascular disease and diabetes is because of the damage of the blood vessels, reducing the blood flow. And diabetes, obesity, cancer all cause hormonal imbalance. It leads to diabetes, leads to nerve damage. It leads to vascular damage. It leads to so many things because of which sexual dysfunction takes place. Psychological factors need to be looked into. But how do you manage it? So you need to identify the underlying cause of sexual dysfunction, treat the underlying medical condition, change medications, provide counseling, recommend a lifestyle change, provide sexual therapy, prescribe medication, and involve the partner. Now, I have just got 20 minutes, so I'll just speak about it quickly. That after identifying the problem, you need to treat the cardiovascular problem, diabetes, obesity, hypertension, cancer, and even any other thing which is compounding, like the age, needs to be looked into. Cardiovascular disease, lifestyle changes as losing weight, quitting smoking, exercising regularly, medications which need to be changed, which do not lead to sexual dysfunction. Diabetes needs to be controlled and it needs to be managed. Obesity needs to be decreased. Cancer, of course, needs to be taken and care. Even psychological care needs to be there. Change the medication if you feel there is a drug which is creating a problem. Provide counseling. Recommend lifestyle changes as weight loss, exercise, healthy eating, and stress reduction. And losing weight can improve sexual function, exercise, of course, healthy eating. What medicines would you prescribe? Well, Dr. Rahul Reddy has spoken before me and spoken in detail on what needs to be given to patients. But three things I would say. The primary root cause needs to be treated. Testosterone needs to be brought to the normal level. Only then the phosphodiesterase work properly. And number three, the couple needs to be counseled to understand what do they really need. Now, this treatment, of course, is the standard treatment. Testosterone replacement may be needed. Antidepressants need to be corrected and they should be given so that sexual dysfunction, if it is there, does not become the side effect of the antidepressants. Involve the partner for sure. Few questions which people always ask me is, what is sexual dysfunction in non-communicable diseases? I always tell them that, well, if any patient is there, I speak a lot among internists, So I always tell them if there is a cardiovascular problem, diabetic problem, obesity and cancer, please look into the erectile dysfunction, loss of libido, premature ejaculation, delayed ejaculation and painful intercourse. This is most important. And how do non-communicable diseases cause sexual dysfunction? Reducing blood flow, hormonal imbalance, damaging nerves, and of course, psychological. What lifestyle changes can help you? Losing weight, regular exercise, healthy eating, stress reduction. And how can a health professional manage sexual dysfunction in these? Every healthcare professional needs to be aware of it and ask this question from a patient. And can medication improve? Of course, it can improve. PDE5s, testosterone become the mainstays. And should healthcare professionals involve patient's partner? Yes, always the partner needs to be involved. Sexual dysfunction is a common distressing problem. Non-communicable diseases in several ways, they damage the blood vessels, hormonal imbalances caused, damaged nerves, lead to sexual dysfunction. Every healthcare professional should be aware of this. Thank you very much. Thank you very much for your time. You've given me a beautiful topic to speak on. Thank you so much.
Thank you, sir.
Thank you. Thank you so much. Dr. Jindal, you have really gave a very informative talk, because usually we never think of sexual dysfunction in non-communicable diseases. I mean, in Gynec Forum also, we take so many workshops and so many CMEs on NCDs, but we never keep a session on sexual dysfunction. So that is an eye-opener for me as well, how important this issue is in these cases of NCD. So very, very informative talk. Thank you
Yes,
so much.
sir.
Thank you so much. Thank you very much.
1 minute, 1 minute. Yeah, 1 minute, 1 minute. Keep it on. Jignesh, 1 minute, sir.
Sir, mail sent.
No, sir is there. You see the Dr. Apur Kumar Datta.
Yeah, yeah.
Yes, yes, sir.
Sir is there, so just make
Sir
him
is there.
post. Because sir has
Done,
joined
sir,
from
done.
that link.
Done, sir.
Make him here.
Sir, Rao sir, we can see you. Hello, Rao sir.
Make him, yeah, I think.
Sir, you have to unmute yourself.
Okay, okay.
Yes, yes, sir.
I'm just renaming my this thing. 1 minute.
Now it is okay, sir. Perfect. It's renamed, sir. Sir, it is perfect.
Okay.
Perfect, yes.
1 minute. Huh? Yes, Dr. Poonam.
Yes, sir. Thank you so much, sir, for giving me this opportunity to welcome Dr. TSS Rao, sir. Sir, I'm really feeling privileged. Sir is a great mentor, and I'm here to introduce him. So Dr. TSS Rao, sir, is a professor, Department of Psychiatry, JSS Medical College, JSS Aher, Mysore. And sir is a past General Secretary, Indian Psychiatric Society, editor, Journal of Psychosexual Health, formerly President, Indian Association for Geriatric Mental Health. He's a former editor also in Indian Journal of Psychiatry. He's a co-chair, Psychiatry and Human Sexuality section. He has done many publications. Many publications are there for his name. And sir is here to talk about the psychiatric disorders and sexual health. Sir, the screen is yours. You're most
Welcome,
welcome.
Rao sir. And I must tell you, sir has helped a lot in formatting this all the concept and all the every topic we have take help from the sir, and all the many faculty we have taken help from the sir to contact them. So very much thankful to you, sir, and welcome.
Thank you. Able to see?
Yes, sir.
Yes, sir.
Okay. At the outset, let me thank the ICOG FOGSI for giving this wonderful opportunity for me to interact with you people. And at the outset, let me also acknowledge that this wonderful job the FOGSI and ICOG is doing, in the sense that sensitizing gynecologists in one of the very vital aspects of their clinical practice is something extremely important. we had some rough estimate of how many gynecologists have married psychiatrists. In fact, it amounts to approximately around 20% of the gynecologists have married psychiatrists. And I was asking my wife why you chose a psychiatrist. She told me, when she discussed this with her friends, they told one of the most amenable branch of medicine is actually psychiatry, and you can handle him very easily. That's what the people have told her. Actually. Of course, psychiatry is something becomes part and parcel of our dealings almost day in, day out. And we definitely need to have some knowledge about what actually the things are. Very recently, one of the marriage was cancelled, and the explanation given in that particular family was the boy was too dependent and highly suspicious. In fact, these are all extremely common, these things wherein maybe engagement or some function has happened, and before marriage, when some time is available, many people realize actually there is something actually going on. Some problem is there. That is one. Second one, if you try to look at international classification of diseases and things actually happened subsequently, World Psychiatric Association classification, it says axis 1 for A, sexual problems for which actually they are seeking help. Axis 1B is actually the comorbidities. And one comorbidity which actually people emphasize is, apart from what was heard about a few minutes earlier, the medical, the psychiatric disorders. And among all the psychiatric disorders, depression actually dominates the whole picture. Many of the times, this actually may not actually manifest at all. And only a little while later, and when you spend a lot of time, or when you are in association with the patient dealing with certain other difficulties, then you realize depression is one of the extremely common problems. So from that angle, keeping in mind, I'm talking to the gynecologist to make it a topic as simple as possible, that you are sensitive to certain areas which you should remember before dealing with the type of problem. The third one, the drugs and other related things, what actually somebody might be taking. One example, antihypertensive, antidiabetics, and all what was spoken earlier, one of the terminology used is as SSRI, which are very frequent drugs used by almost every branch people. So one should be aware of what all these treatment emergent sexual dysfunctions, how to actually deal with those things. I'll try to reduce this picture 1 minute. I'm not able to get the cursor. 1 minute. Okay. It is said that sex lies at the root of life, and we can never learn the reverence of life until we know how to understand sex. And when you are trying to talk about sex, sexuality, sexual medicine, it is a conglomeration of so many branches, starting from anatomy, physiology, culture, interpersonal relations, developmental experiences. Ultimately, what I'm trying to convey the message is that it is a multidimensional concept. And when we are trying to talk about human sexuality, sex is actually a very broad terminology. It actually talks about what you are to, how you deal with life, or your relationship issues to reproduction. So it's one of the very, very broad concept, and one should keep it in mind. Identity, relationship, behavior, and physiological functions. And one should look into almost each of these areas, how actually the things have impacted on. And many of the times, the problem could be in more than one areas. When you are trying to talk about schizophrenia, the domains have affected actually not one, there are multiple. You look at another case of maybe depression. He's also having diabetes, and he's also having a coronary event sometime back. That means, what are the issues that need to be kept in mind? Understanding human sexuality is a very broad one, and psychiatric disorders are two of the important things one should almost always keep it in mind. We almost always speak about two major areas. One is identity related to those things, and now classification and a lot of things have brought in a whole lot of changes and no more considered as a problem unless, say, for example, gender dysphoria and things like that. Unless individual is very distressed, should not be considered as abnormal at all. Too, what Marston Johnson mentioned about desire, arousal, and orgasm. You talk about Kaplan or Marston Johnson, they were all considered as physiological responses. What it meant was that at one particular time, if somebody can bring about erection in the man, the whole problem will get solved. And we are all well aware, there are studies available done on extensively in couples that use of PDE5 inhibitors and something like that purely as something like bringing erection is not going to solve problem at all. The problem here is actually that the seventh component, what Levine mentions, that emotional satisfaction is one of the extremely important. Those who regard it as something positive, who indulge in sexual activity regularly, in fact, these are the people who can continue to be sexually active much of their life. And in fact, this is one of the very commonly reported diseases. Those who carry the negative regard, that means which are associated with personal inhibition, hostile and critical attitudes, limited sex. In fact, this actually keeps on disappearing, and a whole lot of issues and problems that actually crop up in that particular regard. When you are trying to talk about desire, drive, motivation, wish, that means it is a biopsychosocial concept. We must almost always keep it in mind, majority of the aspects together. And yesterday in the presentation, this particular point was brought up by at least two presenters, what I have heard yesterday. What it means is, when there is a problem in desire, it is likely to impact on what we basically call the arousal problems also. This invariably impacts on what you call orgasm. So this is actually either you talk linear model or circular model. In both the ways, this is likely to affect in one way or other. And this is one of the aspects one should almost always keep this point in mind. Why this is important? One of the things actually people have documented is actually sexual disorder itself as one of the psychiatric disorder. Now the current classification, if you try to look at, say, ICD-11, this has been made into a separate category of disorder, taken off from psychiatry section. The medical or psychiatric disorders, when we are psychiatric disorder, when we are trying to talk about, sexual disorder both has cause and effect type of relationship. That means on its own right, this happens because of these problems, and this can actually lead to the other problem. What it means is, say, for example, if you try to look at when somebody is having sexual disorder, we are all well aware leads to low self-esteem, significant interpersonal troubles, dissatisfaction with life, and low quality of life. So these are the few of the things which actually people have documented in very significant way. In the same fashion, if you try to look at depression, anxiety, and the use of substances, drugs, all these three things have been actually very closely related to this particular aspect. You might have seen hundreds of movies wherein actually the failure in love to, in fact, marriage and other related things have actually impinges on individual's life. So that means it can affect in so many ways. And more than anything else, see, in our JSS hospital, we have a sexual medicine special clinic next to diabetes clinic. As in time went by, we realized that sexual problems are extremely commonly associated with these individuals. When the issue came that this diabetes not properly treated or irregular with the treatment or uncontrolled diabetes, they can affect sexual problems. And this particular link has been established. People's adherence increases significantly. Relapse prevention to, in fact, compliance with the drug usage. This is one of the very important area that was actually documented with them. What it means is actually they may not voluntarily disclose. It is our responsibility that we make inquiry. Do you have any sexual concerns to talk to us? Do you have any sexual concerns currently between you two people? In fact, one or two questions like that can break the ice, and the individuals actually they come forward with many significant areas of problems or difficulties actually what they are going through. This particular diagram I invariably actually focus to bring to the focus that when we look at this picture, we may feel that there may be one horse or two horses. But look at very closely, there are about 5 horses in that particular picture. Sexual problems are like that. In fact, the data is available in great extent. Almost 1/3 of the male population, half of the female population have significant sexual problems. And when you try to treat them with, say, in our psychiatry, with antipsychotics, antidepressants, the problem becomes double. What it means is there is a direct relationship, cause and effect relationship between disorders, treatments, and the people who are actually presenting with sexual problems. Try to look into a whole lot of things that maybe actually be one actually need to look into when we are trying to talk about psychiatric disorders. Other issue is actually the personality related issues wherein people find it very difficult to establish relationship. Other disorders which actually impinge on what we call the formation of relationship. Inappropriate behavior sometimes in some of the psychiatric disorders it's possible. Specific deficits in physiological functioning leading to erectile dysfunction, premature ejaculation, and things like that. And invariably, there is an overlap and complex functioning among all these type of disorders. So one should almost always be keeping in mind what actually we are trying to deal with. And it is one of the very complex and very significant area one should keep it in mind. What are those 3 very important areas? Again, I have just brought in this particular slide to emphasize point. Range of difficulties may be relation to relationship and sexual function. Quality of life affected significantly. And it may not, they voluntarily disclose. So it is our responsibility to see that, in fact, their concerns are resolved. That way, they continue to take medication or whatever we call treatment regularly. There are a whole lot of ways actually this can be classified. One is actually the predisposing factors for any of the sexual problems, like say lack of information or lack of knowledge in this particular area. Precipitating factors, say somebody is having some medical problem, some psychiatric problem, along with that, what we basically call childbirth, infidelity related to other related issues. Maintaining factors like say interpersonal issues, family stress, work stress, financial problems. Like that way, in fact, there are a lot of things actually, each one leading to the other, and a combination of a whole range of issues is actually something one actually frequently encounters. When you are trying to talk about gynecology and practice, the fear of pregnancy and related things, relationship issues, even related to either pregnancy, infertility, and a whole lot of things, lack of feelings, guilt feelings, stress related. That means the number of problems actually one would be trying to look at, one has to go through adequate details to get into what we basically call the crux of the problem. When we are trying to talk about relationship issues, see, many of the times you look at, there are certain disorders where the individual finds it very difficult. I still remember very closely in one of the very close relationship only, the engagement function over and this particular person, I make phone call to him, but he doesn't respond at all to that. But ultimately this particular, again, marriage didn't happen. Poor communication, showing anger, conflicts, and which actually they find it very difficult to clear themselves, lack of respect, loss of love, and interactions among the above 6 factors leading to a whole lot of this thing. That means relationship is one of the deep important component. And when we are trying to talk about female sexuality in particular, this is one of the very, very important to this. And somebody is having major psychiatric disorder, or specifically psychiatric disorder, the partner's helpful attitude is extremely important. Otherwise, in many of the times, we find it very difficult to handle. Nowadays, if you try to look at any of the books, people don't talk much about a whole range of psychodynamic factors. But I always feel we should not forget. The Freud mentioned about conscious and unconscious mechanisms, what actually might be happening. What we don't see is actually much more interesting than what actually we see. There are a whole range of what we call the type of interaction happens between these two. The unresolved conflict and such other these things, which actually interferes with, and developmentally speaking, in fact, I have not gone into the developmental aspects in great detail, except that the girl child starts development with actually something missing, and because of which actually feeling little low in certain aspects, and how it actually impinges later on what we basically call their marital relationship, the Oedipal electrocomplex and such other those things, wherein unless it is resolved properly, the identification with the same concerned parent and actually, in fact, forming mature interpersonal relationship with the partner may not be possible. So the whole range of defense mechanisms, these are all called as unconscious or involuntary defense mechanisms. We call people deny, distort, project about what is going on in the mind on to the other party, and they impact that particular way. The magical thinking and fantasy. Well, each one of these type of things can be elaborated in great detail. The psychologist would be very fond of talking about this in great detail. But all said and done, one cannot be just blind to some of these type of things that might be happening in the relationship. Coming to neuroanatomy, physiology, and the biological aspects, we are all aware that, see, when you are trying to talk about psychiatric disorders, one of the lobes which is very dominant, emotionally speaking, is actually limbic system, and it is also called as animal brain. We all behave mature way because the newer brain, which actually has prevented us from being aggressive, wait for the good response to come, calculate all the things and behave properly. So many of these type of things are actually very important aspects. People have documented how precisely stimulating certain part of the brain, how actually the individual responds. The Pape circuit, in fact, when we are trying to talk about anything rewarding or in fact pleasure giving, starting from what we talk about, see the septal area in the front, which is actually nothing but in fact the sex center also, to the whole range of things, starting from circuitry, covering many of the important areas, actually can get disturbed in so many ways in certain disorders. And psychiatric disorders are one of the classic examples in that particular fashion. The damage to both, say, for example, amygdaloid body on either side, the Kluver-Bucy syndrome, where hypersexuality, hyperphagia, psychic blindness, and hypermetamorphosis, these are all few of the things actually people have documented wherein the animals present that way. And some of these cases have been documented even in what we basically call human beings too. What I am trying to tell, there's a whole lot of explanation available to understand, biologically speaking, there are a lot of things are there. When we are trying to talk about psychiatric specific disorders, I'll come 1 minute later. One of the most important neurotransmitters is actually catecholamine related, and among that, the dopamine mechanism. I have not gone into, say, epinephrine, norepinephrine, and things like that. See, dopamine is one of the things, it's primarily excitatory. It mediates pleasure, increases sex drive, promotes orgasm. And you try to look at all antipsychotics for all practical purposes, they are all dopamine receptor blockers. That means automatically you can expect one or other sexual problems also in these individuals. And if you try to look at those which are drugs used in case of Parkinsonism, things like that, wherein actually which increase dopamine, there's a very significant increase in actually what we call as the erection, sustained erection for a long time, painful erection, and all of these type of things have been documented. Serotonin. When you are trying to talk about depression, serotonin is one of the key important things. What actually being said is that serotonin is actually one of the neurotransmitter which acts like the body's internal schizophrenic. What it means is there are some people who respond extremely well. They are cleared of sexual difficulties, but there are other category of people who actually land up with a whole lot of difficulties and problems. What it means is there are multiple different 5-HT receptors there in our brain, and each one of these things has a different function. 5-HT1A facilitates actually sexual function. 5-HT1B, 5-HT1C, 5-HT2, all of them can actually impair sexual functioning. Ultimately, what I'm trying to tell you, depending upon what receptor mechanism some drugs are acting, based on that, a whole lot of things can actually get into. On the left side, we have actually marked paroxetine. Paroxetine, when you look at historical development of 5-HT, this SSRIs, fluoxetine, then subsequently escitalopram, fluoxamine, sertraline, paroxetine. Paroxetine is the last one, highly sedating. But one of the important point about this particular molecule is that it is actually acts like nitric oxide synthase inhibitor. What it means is, at a very small dose, it is one of the highest inhibitor of what we call ejaculatory response. And because of which this has been used for the early ejaculation or premature ejaculation as one of the very commonly used drugs. But if you give the dose a little higher, the individual will end up with a whole lot of erectile dysfunctions and such other problems. So what I'm trying to convey again, the message here is one should be very well aware and clear about the mechanisms and other actually things these drugs act, and that way one can prevent what we basically call the treatment emergent sexual dysfunctions. SSRI-induced sexual dysfunction was more severe in women than in men, and not being able to reach orgasm is one of the extremely common component one has noted with the SSRIs. This is a diagram just to indicate there is a whole lot of interrelationship actually between autonomic nervous system, neurotransmitters, and hormones, which ultimately leads to both either promotion or inhibition of sexual functioning. And very clearly in the last lecture, this was brought out. There is one more thing actually what one should remember. Earlier we should talk about testosterone, estrogen, and progesterone. But now things are actually slightly different, and wherein we have to actually keep it in mind. There is something called oxytocin, which every gynecologist is actually very familiar. Estrogen is positive, testosterone and progesterone. Together they act quite differently compared to, in fact, what we call individually. Progesterone is actually can be quite a problematic hormone from sexual functioning point of view. For initiation of the activity, testosterone is necessary. The receptive, permissive, in fact, response, female estrogen hormone is actually one of the extremely important component. Coming to the oxytocin, now it has been documented that at least in case of females, the orgasm is possible because of the oxytocin effect, and this is one of the key hormone which actually leads to the what we call as the orgasm, at least in case of female. So there are different neurotransmitters are there, hormones are there, which are actually positive and negative. That's what actually the earlier diagram was also what we were trying to talk about. When we try to talk about dopamine, and one of the other hormone is actually prolactin. We are all well aware, say for example, following delivery, there is a significant drop in what we basically call the sexual interest, desire, and arousal in case of females. And this has been attributed to the prolactin because of the milk secretion, sucking, and various other such behavior the child presents. So there is inverse relationship between dopamine and prolactin. Dopamine actually one of the exit hormone and absolutely necessary. See, there is a new car and the bride is there and he opens the door, means it is actually the dopamine effect. Prolactin can be exactly opposite way. It acts and it is actually acts like an inhibitor. And any given time, the female sexual response, more particularly the desire and arousal we are trying to talk about, is lower mainly because of some of these neurotransmitters which are actually there in plenty. And when we are trying to talk about antipsychotics, antidepressants, other psychotropics, each one has a very different type of effect. Some are very highly inhibitory too. There are some actually which are better. Each of these drugs, when I talk about it, I'll talk again some of these type of things. But in this particular diagram, for example, opiates. Those who are dependent on opiates, in fact, he is able to get the pleasure out of this particular opiates itself to an extent that, in fact, all interpersonal relationship and other related things with the partner becomes too secondary for the individual. One may be giving 5-HT2 antagonists to a whole range of, say, sedatives, hypnotics, and all of that. Do remember, each of these drugs have some effect or other. Ultimately, cumulatively, an antidepressant, when this particular person is having high level of anxiety and he wanted some sedation, that means some of the drugs what you are giving to, he was having little gastric irritation, for which you add another group of medication and something else. Do remember, each of these type of drugs can actually produce significant problem. Coming to psychiatric conditions, one can talk about it for, in fact, our students learn it for about 3 years. See, common anxiety disorders, mood disorders, depression, bipolar disorders, schizophrenia, and developmental certain disorders. Substances actually, in fact, one can talk about many things, but alcohol, opioids, cocaine, cannabis, and other stimulants, and neuropsychiatric phenomenon, which can actually create problems. What actually has been documented is each of these disorders have extremely well documented sexual dysfunctions. But the point is, which one is better and all, actually what one can has to look into, and the type of conditions, we should not try to do anything which actually aggravates the problem among these individuals. So among coming to psychiatric disorder, what we should remember, one is sexual dysfunctions. Both qualitative and quantitative changes are possible in these individuals. More than one problem. It can affect desire, leading to arousal problems, and then to the orgasm problems. Sexual dysfunction leading to psychiatric disorder, secondary depression, and many other such things are very well documented among these individuals. Many psychiatric disorders have sexual etiology. If individual has associated paraphilic and such other disorders, which constitute specific behavioral disorder, both as causative, consequential, coexisting. Say, for example, an individual presenting with the mania. At that particular time, certain types of behaviors, what he presents may look like, or in fact resembles what we basically call the paraphilic type of disorder. So one should keep it in mind what we are actually trying to do. In a Parkinsonian individual using anti-Parkinsonian drugs, more particularly the dopamine-related drugs or dopamine agonists, in fact, some of them can present with hypersexuality to, in fact, a whole range of paraphilic type of behavioral symptoms. When we try to look at a specific disorder, like say, take an example, schizophrenia. No sexual dysfunction earlier, or if somebody is having actually personality and such other changes earlier also, with the onset of psychosis, report sexual dysfunction at some particular time later, not because of anything, but because that is the time lapsed between the progression of the illness and actually the type of sexual dysfunction and different have come up. You try to initiate problem, the problem becomes actually significantly more. More the complications, more treatment methodologies actually you are trying to combine, escalation of the problem. So that means all of these things are possible in case of any of the actually disorders. So when you are trying to talk about schizophrenia, we're all well aware, schizophrenia, one of the terminologies as it indicates the split-mindedness, but that is one of the old concept. What it means is actually there is no harmony between our affect, thought, perception, and many of the other psychological functionings. Sex therapy may not be effective because the individual has impaired contact with reality and profound distortion of relationships. It may not be applicable to all the individuals with schizophrenia, starting from acute schizophrenia to very classically named schizophrenic syndromes. You talk about catatonic, you talk about hebephrenic or paranoid. So paranoid syndrome is and catatonic are grouped under what we call as good prognosis schizophrenias. What we basically call, there are certain types of schizophrenias where the deterioration would be so fast and so significant that it can affect the individual's life in a very significant way. The physical aspect of sexual intimacy gets affected in a significant fashion. Emotionally, they remain detached, remains uncommitted, frequently with sick qualities such as sadism. Sex therapy may threaten the patient's defense system. That's why, say, when you are trying to talk about some of the psychotherapeutic techniques, better avoided, and most probably the relaxation, such as the techniques like say yoga and other related things, we actually advise, in fact, contraindicated in these cases. Has to be undertaken by in collaboration with psychiatrists, because each and everything what you try to do may have an impact. Sexual desire is one which is the most likely to get affected, schizophrenia in general, or when you are trying to actually indicate treatment with certain ways. And when you try to treat these individuals, sexual side effects are common. Discontent or non-compliance is extremely common. It is not only seen in diabetics and hypertensives, possibly in schizophrenia, this may be the commonest issue. Issue of appearance of metabolic syndrome leading to weight gain and associated smoking and drug alcohol use, medication side effects, all combine and accentuate the problem. No evidence of one drug superior over the other. Say, for example, whether olanzapine is better than risperidone, whether clozapine should be given, protection to side effects. See, the issue here is actually not one simple, easy to make general statement, for the simple reason that when you are considering close-up in, usually this drug is considered where people have failed in other drugs and what we basically call drug resistant to lot many other things. So that means it is not a level playing ground for making drug comparison between one to the other. Some of the drugs which are actually least likely to have sexual problem, say quetiapine, aripiprazole, clonazepam. In fact, these are things so reportedly actually the least amount of sexual problems. And what actually the science says is these antipsychotic induced sexual dysfunctions, particularly erection, can be reversed by what we basically call PDE5 inhibitors and if used properly. You look at the range of antipsychotic drugs available. Earlier, classical antipsychotics like, say, phenothiazines, hyperprolactinemia, and such other things were common. With thyroidism, priapism, actually once or twice, in fact, it has been reported in the literature. Thioxanthine, arousal problems, haloperidol, similar problems like phenothiazines, and volazim, possibly less sexual side dysfunction due to lack of prolactin-related effects. Priapism is reported rarely in some of the cases.
The last 5 minutes.
Hello?
Last 5 minutes, sir.
Last 5 minutes, sir. Okay. Risperidone and so many other group of drugs, each one has actually having one or other side effects. When you're using psychotropics, one important point is actually they ameliorate disorder, but actually they produce a problem. And so one has to actually keep it in mind how actually to go about, and whole range of clinical trials. And when many of the times, many of these trials are actually published by pharmacological pharma companies, many of the negative components actually they might have not reported. Depression is extremely common to be associated with what we basically call sexual problems. Mania, when we are trying to talk about bipolar disorder, can present with hypersexuality and things like that. People have documented any number of studies available to say that, in fact, depression, mild, moderate, severe, how long, how prolonged, how it has become chronic, each of these type of things. The earlier studies used to document, in fact, fluoxetine to, in fact, paroxetine, paroxetine as the highest blocker of what we basically call ejaculatory process. Tricyclics, MAOs, and other related drugs. In fact, each one of these things the people have documented. SSRIs in general, of course, this is the figure available. You take an example, say fluoxetine, around 20-30% range. Some of the drugs like mirtazapam, around 20 to 30%. Reboxetine, very much less, maybe 5 to 10%. And what actually I can say is agomelatine, no reported sexual side effects. And this is one of the paper what we actually published. What it actually speaks about is the newer drugs like vortioxetine having agonist property and no sexual side effects. Two, vilazodone and things like that, which are all partial agonists, can produce certain types of problems. So treatment, one has to be very careful about what drugs he is using and how. And this can be corrected by the range of things actually, including for what we basically call the sildenafil and things like that, actually correcting. Alcohol, in fact, it increases the desire but takes away the performance. What actually is Shakespeare mentioned to range of these things. In fact, each and every body aspect is affected because of these things. So people have documented one or other sexual problems and difficulties with each of the substances. And when we are trying to talk about pharmacological intervention, review non-psychiatric medications, reduce the dosage, provide drug holiday, where necessary 5-phosphodiesterase inhibitors, addition of dopaminergic drugs in certain specific conditions, say like an example, depression. Anxiety, depression, psychosis, and each of these things are very well known. How to go about recognizing properly if there is a particular specific psychiatric disorder is contributing, specific cause is present, trying to be treated properly. One may have to withdraw, one may have to modify the usage, or go for the drug which is actually better placed in that particular area is one of the things actually what one has to see. Drugs alone is one aspect of it. The other important aspect is actually whether they are psychologically sophisticated or not. Based on that, pharmacotherapy, non-pharmacological treatments, and combination. This is actually one of the other steps actually we try to follow. Sexual myths and misconceptions are extremely common. Try to correct it. relatives and others getting significantly anxious and leading to. In fact, many of the times when the individual is having psychiatric disorder, his parents, in fact, the girl side, her parents or relatives, where the issue becomes too complicated, and many of the times we actually fail to treat them, actually not because of anything, but because so many other psychosocial issues that are actually involved. Carry home message. This is what actually WPA classification talks about. Clinical disorders, axis 1, other mental and general medical disorder, what actually it says is, keep it in mind, depression as one of the extremely important this. Disabilities is the axis 2, where personal care, occupational issues, spouse or partner issues, other relatives and social. You look at psychiatric disorders, each of these areas can get affected. So none to massive, certain particular specific rating scales too. In fact, the contextual factors, the family, education, economics, and many other such things, all of these things are extremely important points. There are particular scales given actually that axis 4, the quality of life, starting from poor to excellent. In fact, they can mark it. And ultimately, clinical problems and their contextualization, extremely important. Positive factors for the each patient, we should recognize and try to change it. And expectations of restoration and promotion. Somebody who wants just medication, these are not the ideal cases for our intensive therapies and all of that. Depending upon what is the range of issues that are involved, one actually definitely need to look. There are newer disorders have committed, relational sexual dysfunction, extremely important to be kept in mind when you are trying to talk about psychiatric disorders. Sexual compulsory addiction, in fact, sexual addiction disorder, this is one more other thing one should keep it in mind. Sexual dysfunctions of resolution phase, which we were not talking earlier. In fact, people have trying to recognize this. Indian Psychiatric Society has come out with clinical practice guidelines, and I am one of the authors for this sexual dysfunction section, available indianjpsychiatry.org. Anytime, anywhere, anybody can access. In conclusion, what I can say is, see, nobody can be made into a Superman or something extraordinary. We can work out, see that pre-morbid sexual functioning he reaches. Primary psychiatric disorder, comorbid psychiatric disorder, comorbid physical illness, one should almost always keep it in mind. And the type of drugs what you are using, medication, psychotic or medical. This is one of the prescriptions I just brought in here because, see, you look at the number of drugs somebody is taking, which drug is producing what problem. So when you say depression related, whether myocardial infarction or SSIs are producing, that means whole range of issues are there, and each case is actually individualized. Treatment plan actually made accordingly is extremely important. Ultimately, what I can say is expectations have to be altered to some extent, and those people who are established relationship, they do well compared to not told earlier and something accidentally arranged marriage, says very maybe something like mental retardation in case of husband, wife. In fact, these are the type of things actually can lead to quite a bit of difficulty. And what I can say, this is already, we have already spoken, sexual problems may appear as part of the illness or as part of the treatment. There is almost always, there is a method to actually to treat. When you are using the drugs, multiple permutation combinations are permitted. What it means is those which act at the central level and those which act at the peripheral level, those which are initiators and conditioners. That way, we need not have to lose hope among any of the cases. Starting from physical therapies to, in fact, ultimately the processes, these are the few of the things which are available. I can conclude this idea with the idea that contempt of sexuality is a crime against life. These people need help to cure sometimes, to comfort always, to hurt the least, to harm never. This is what actually the Socrates mentioned. With those few words, I'll just conclude my presentation. Thank you.
Thank you very much, sir. Lakshmi madam.
Yes. Thank you so much, Dr. Rao, for giving us such a comprehensive overview of psychiatric disorders and sexual health. It was very, very informative, and I'm sure all the delegates have been benefited by this aspect of the sexual health from your talk. So thank you once again.
Thank you, madam. I'm trying to get out of this. How?
Now, Neeraj, I think we can start with the post-test.
Yes.
And before you give answer, I will give concluding remarks. You show answers and then we will say tata. Bye-bye. Yes. So, Jignesh, you are with us?
Please
Yes,
check
ma'am.
box.
Shall I post, ma'am?
Yes, please. So, dear delegates, we are starting with the post test. He has posted the link in the chat box. Please click on the link and start giving your post test. Time given is 10 minutes. And meantime, we all will be muted so that there is no disturbance for you all when you are giving your post test. Just keep an eye on the time. कितनी टाइमर लगा?
5 minutes. Four minutes left. Last 2 minutes. So time is over.
Time is up.
Yeah.
Yes.
So relax. Don't worry. I know today's session was about male sexual dysfunction, psychiatric component, non-communicable disease. So some of you may find little bit tough, but don't worry.
Yes. So
We will count all 3 days tests. So don't worry. So should I share the answer?
no, just wait.
Yeah.
Let me finish with my concluding remarks,
Okay.
Neeraj.
Okay.
So friends, I'm really happy as a ICOG chairperson, and this time we covered this unusual topic under the ICOG forum. And why? Because talking about sex is still a taboo in India. We all talk about physical, mental, spiritual, financial health, but we never talk about sexual health, which is so vital for the overall well-being of the person, the couple, family, society, and nation at large. It is so unfortunate that common source of sexual health knowledge for our young doctors, it is still from friends, pornography, and magazines. But what we all want, we want them to acquire this knowledge from medical textbooks, which are based on scientific knowledge, and that will provide them with the knowledge about diagnosis and management of sexual health disorders. Unfortunately, the topic is often ignored in the syllabus and training, but it is high time to change the current medical education and regulations of India, and our policymakers and stakeholders, they need to address the sexual health of people. To produce more trained professionals, a sexual health module for undergraduate medical education should be implemented. And this is what we are advocating to the stakeholders and policymakers, because otherwise, how can we expect our physicians to address these sexual health disorders? Even in the syllabus of postgraduate students of related specialties, topics like female sexual dysfunction are not taught. And that is why we feel ill-equipped to handle with these cases. So the person or a couple who is having sexual dysfunction, they are also not aware where to go. So they start going from quacks to physicians, to gynaecs, to surgeons, urologists, psychiatrists. But it's high time to have a specific post-graduation course of Doctor of Medicine, which can be introduced for sexual health to provide experts in this field. And that is why ICOG is working hard to get a recognition as a college status. And we are very serious about introducing this teaching module in the postgraduate training, because if we include this, we can have competent doctors who can handle these sexual disorders in the society. Agree, today we had included the male sexual dysfunctions. As a gynec, we don't treat, but we do treat female sexual dysfunctions willingly or unwillingly. We all must have learned that female sexual dysfunction is quite prevalent in India. 40% women, they suffer in silence. And I hope, seriously hope, that this 3-day course has contributed to your understanding of various issues of female sexual dysfunction, its classification, history taking, how to counsel, how to evaluate, and how to treat these cases. And I'm so happy that today we discuss in detail about the adolescent sexuality as well. So I really hope that you all are better equipped to handle these complex situations after attending this FOGSI ICOG certificate course on sexual health. And I am happy with your interaction, your enthusiasm, your participation. And I am so thankful to all the faculties for sharing their wisdom and experience with you all. And I wish to place my sincere gratitude and thanks to our course convener, Dr. Neeraj Jadhav, who came out with this wonderful module. It is his choice of topics and speakers. Neeraj is simply commendable. And so happy. I also learned a lot, and I'm sure everyone has learned from this 3-day course. So Neeraj, thank you, and back to you for showing the answers. And still there are many queries related to pre-test, post-test. Friends, if you have given post-test on all 3 days and you have just got 50% marks in all the 3 tests, we are very, very liberal in giving you certificates. Do give us 1 month time because it takes time to process all the data and see who are eligible and who are not eligible. If you have any issues, any queries related to your certificate, please contact ICOG office and we will look into your queries. So Neeraj, back to you.
Yeah, thank you, Lakshmi Madam, for giving us this opportunity, because we were so much delighted when you asked for this course, because it was need of our. We
Yes.
felt in many webinar of our with different society, they asked for this course, and finally this happened. So it is a long 3 days, 12-hour exhaustive course, but we are happy that we can do that. So thank you very much. Let me share the today's post-test answer. Can you see?
Yes.
Yeah. Okay.
Yes, sir, it's visible.
Yeah. So question number 1, answer was E. That is any of above. Question number 2, answer is again E. That is all of above. Question number 3, answer was B, that is all of above. Then question number 4, answer is A, that is phenylephrine. Question number 5, answer was B, that is prolactin. Question number 6, answer was D, that is all of above. Question number 7, answer was D, that is all of above. Question number 8, answer was A, that is if partner to have a delayed orgasm. Question number 9, answer was A, that is result in ED. Question number 10, answer was A, that is offline drug for PME. Question number 11, answer was C, that is any of above. Question number 12, answer was A, that is prostatitis. Then question number 13, answer was C, that is 10 to 19 years of age. Question number 14, answer was D, that is accident. Question number 15, answer was A, that is by the 2 year. Question number 16, answer was B, that is searching for an identity and their role in society. Question number 17, answer was C, that is depression and self-harm. Question number 18, answer is C, that is gender identity. Question number 19, answer was B, that is diabetes. Question number 20, answer was A, that is decreased vaginal lubrication. Question number 21, answer was C, that is heart disease. Question number 22, answer was B, that is cancer. Question number 23, correct answer was answer D, that is antibiotic. Question number 24, correct answer was answer A, that is prostate cancer. Question number 25, correct answer was C, that is separate category. Question number 26, correct answer was answer B, that is culture bound syndrome of semen loss. Question number 27, correct answer was answer A, that is schizophrenic disorder. Question number 28, correct answer was answer A, that is double the sexual problem. Question number 29, correct answer was answer B, that is vortex setting. And last question, question number 30, correct answer was answer B, that is decrease in the sexual desire. So if you have all the lecture with the concentration, all the question were from talk only, No outside question were there. So I hope you have answered most of the question right, and you will get certificate. So best of luck to everyone, and thank you for joining. And I hope this will make a difference in your day-to-day practice, and it will help eventually to your patient. Thank you. And thank you to my team, Dr. Apurva, Dr. Manoj Bhai, Dr. Madan, Dr. Vani, Dr. Queen, Dr. Dilpreet, Dr. Uma, Dr. Sama, and Dr. Poonam, who has worked behind the curtain to manage all the things so work can go on smoothly. So thank you, my team, for efficient work and making this program run smoothly. So thank you. Thank you, Lakshmi Madam.
Thank you, Dr. Neeraj.
Thank you, sir.
Yeah. Jignesh, you can stop the recording and you can end the